Morning, all. I'm audible till the last. Excuse me. You can hear me? Okay. So I get everybody register yourself. Hello. Hello, participants. I'm saying you're registered. Okay. Good morning, everyone. Respected dignitaries, eminent speakers, honored guests, faculty members, researchers, innovators, and students, and all the participants. It's my pleasure to welcome you all to the Innovator Workshop on Health Technology Assessment. The workshop is organized by Resource Center of Health Technology Assessment, Jodhpur, collaboration with Department of Health Research, Government of India, IIT Jodhpur, and the Research Hub HTA IIH Gandhinagar. I am Dr. Anjali Saini with my co-anchor Sanju. We are delighted to host for today's program. Over to you, Sanju.
A very warm welcome to each one of you. Today's workshop brings together clinicians, engineers, researchers, innovators, policymakers, and public health professionals to discuss how technology assessment can strengthen healthcare innovations and evidence-based decision making in India. We sincerely thank all of you for taking the time to be with us today. Invoke the blessings of Goddess Saraswati and mark the auspicious beginning of today's workshop. I respectfully invite Dr. Kuldeep Singh Sir, Dr. Soman Saha Sir, Dr. Dhaval Parmar Sir, Dr. Subhash Srivastava Sir, Dr. Ankush Sharma Sir, and Dr. Varuna Vyas Ma'am to kindly come forward for the ceremonial lamp lighting, followed by Saraswati Vandana. May I request everyone to kindly stand up for the ceremony?
Oh, start with the blessing of Saraswati Ma. Thank you to the respected dignitaries for the auspicious lighting ceremony and Saraswati Vandana. May I now request Dr. Kuldeep Singh Sir to kindly present bouquet to all our esteemed speakers and dignitaries. I request to all speakers and dignitaries, please come forward. Dr. Soman Saha Sir, Dr. Dhaval Brahma Sir, Dr. Siddharth Srivastava Sir, Dr. Ankur Sharma Sir, and Dr. Varuna Vyas Ma'am. Please, guys, round of applause, a warm welcome. To formally begin today's workshop, I would like to invite Dr. Kuldeep Singh Sir, Principal Investigator, Resource Center, Health Technology Assessment, and Jodhpur to deliver the welcome address and inaugurate today's workshop. May I request Kuldeep Sir to kindly address the gathering.
Good morning, everyone. It is on this day we are having this special workshop, and it is our privilege from AIMS Jodhpur that we have a very wonderful program, which is a medtech program jointly by the AIMS Jodhpur and IIT Jodhpur. And here we have the innovators from the IIT Jodhpur and AIMS Jodhpur who have joined here for this special cause. And the objective of this today's workshop is that as an innovator, we mostly devote our time towards the development and refinement of our innovation. We never think of beyond that, how it can be commercialized or taken into a venture. With the Government of India policy of Make in India, in order to make the technology affordable to the common man in the healthcare, the many of the things have been initiated by the Government of India. And for this cause of Make in India to have the affordable technology available in our country, many steps have been taken. And one of the steps is that health technology assessment in New Delhi under the DHR, ICMR, which is the coordinating center throughout the country for taking care of the capacity development, advocacy, as well as development of the manpower, and to provide the regulatory evidences for the government and the user to take this technology. To this end, this ICMR is also taken to join hand with other agencies. For example, there is a MedTech Mitra. MedTech Mitra is especially it is a hand-holding type of mentorship program for the innovators. And it can be joined by any of the innovators at any stage. Once the technology has got the regulatory approval from the CDSO or other agency, then it can be put forward for the HTA, Health Technology Assessment. And the Health Technology Assessment with the help of 28 resource center and 6 resource hub. They guide, they study, and they also find out whether this technology, the technology by the innovator, how much it is the economic benefit for the country. In a simple term, what we can say is that if a technology is available, then whether it is affordable, whether it is useful, whether it is user-friendly, whether it is having an impact on the healthcare, whether we can compare by the reduction of the mortality or morbidity or the use of any index like quality of life improvement. So all these things are the one of the factors which are assessed through this technology. So it is basically a scientific process. It is a scientific process in which the technology is assessed for the economic impact. During today's whole of these sessions, we'll come across many of the terms which are very new to the all of the innovators. And it is very important to understand all these terms. Our country has a limited resources, whether it is a technology, device, drug, or a human manpower. And how to optimize the use for the healthcare is one of the aspects of the economic evaluation of our HTA. So HTA through the resource center and the resource hub, they take the responsibility to do the scientific evidences collection. And this scientific evidences goes to the multiple level of approvals. And ultimately, they are converted into policy briefs. And these policy briefs are then put for the government to take the action. So no doubt that our innovators can also reach to the policy level also. And when they understand what is the process of the health technology assessment, it makes our process much easier. It makes our process much easier to understand and to also put effort in our technology so that it is more useful. While doing all this study, the part of the HTA is also to assess whether there is any side effect or not, whether there is a contraindication, whether it is can cause damage to the society also. So we have to assess the environmental assessment also in any form. So when you are preparing the technology, our concentration goes only to our product. We are we have the endowment effect toward the product we have made, but we never think from the other side. So have the thinking from the other side, whether it is useful in the terms of environment, ethically correct or not, morally useful or not. So all these terms, all these things are also discussed as a part of the health technology assessment. In the today's workshop, there are many innovators are there, and we have come to know that there are 15 startups from the IT Jodhpur, AIIMS Jodhpur, and some of these startups are now accumulating more than 6 crore amount of money as a financial grant for improving their product. So this is very heartening and it is pleasing also, and it is like motivating for other innovators also. That is how we can go venture into these aspects to improve our innovations so that it becomes useful for the country. And it is also, we are pleased to welcome all those new entrants who have joined recently in this month as the MedTech students. Just for the information of everybody, the AIIMS and IT Jodhpur have joined program started in 2020. Initially, there were three components. That was the master's degree, PhD, and dual degree, MD, PhD, master's PhD. But later on, the dual degree was dropped because it takes a longer time, even up to 6 to 7 years. So that's why it was dropped. Now they have two components. That is the master's, which is 2 years program, in which the medical and allied innovator and the engineering allied innovator join hand for a one product, and they work on that to find out the prototype of that product. Whereas the PhD students, they work on a depth of this knowledge to create something which is in a long run can have the more impact, and into deeper into the studies of these. So the PhD program is carried out by the candidate along with the three guides, one from AIIMS Jodhpur and two from IT Jodhpur. And these guides, they mentor, they guide, and with the philosophy in mind that a product should be useful for the society. So they have to choose an idea. Much of the time is wasted or like spent in finding out which product can be more useful, which idea can be more able to commercialize. So vote for the new and the senior batches. I would also say that there are multiple things when we start innovating and we are aware of the value of death. That is, when you start thinking of an idea, we think that idea is our own and it is only once in the world we are creating this idea. But believe me, there are many more people who are working on the similar idea throughout the world. So what we have to do is we have to try to find out who else is doing all this work and what the challenges they are facing. So this is first step in understanding your idea. So sometimes the idea is left behind. There is a valley of death. Another, when it is going into the prototype, it may not be taker. They may not be taker. Another valley of death. So that's why we have to understand the system. That is how the innovation progresses through different phases of lifestyle. Second thing we have to understand is that there's a concept known as technology readiness level, TRL, from 1st to 9. So we have to understand what is these TRLs, different TRLs, and at what stage we can apply the HTA. At what stage we can go to the MedTech Mitra, and at what stage we can go the full HTA. So this is also very important. And today's workshop will highlight some of these aspects also. So we have with us very eminent experts, and we have Dr. Sumen Shah, who is the resource hub in charge at IAPH Gandhinagar. Along with him, Dr. Dhaval Parmar is also at resource hub Gandhinagar. And also we have Krishna Sahu, who is at the main HTI in Delhi. with the DHR. He is going to speak on some of the evidences about the adoption of the medical innovations in the public health programs. We have Dr. Siddharth Srivastava from IT Jodhpur, Professor of Practice, and he knows about the system, how the innovation program is developing, and what are the challenges we are facing, and how we can overcome them. So he has a very wonderful talk about how this program is developed and what are the things which have been achieved by this program. This is a program, the IT Jodhpur MedTech program with the AIIMS Jodhpur is one of the flagship of the Jodhpur city, and this is being now considered as a model for any other medtech innovators throughout the country, and they are trying to adopt. They are trying to go about it, and they are searching for the places where the AIIMS and IITs are together, and they are also looking for the places where IITs, AIIMS, and the IIMs are also together. So they are also thinking about starting this program to some extent. Some of these are successful. Even the Indian Institute of Science, they have also ventured into the master's program or a PhD program in the similar line, medical technology. Recently, we have IIT Bombay. They have started this program with some of the 10 startups, 10 innovators. And although they have a standalone, but they are contacting with the clinicians throughout the city. So there are so many things are happening, and there's a lot of scope of the technology also. But at the same time, the purpose of this workshop is to apprise you of some of the basic concept about what is technology assessment. When we say health technology assessment, our minds or anybody minds goes to the technology only. But here the technology not only means the device or the drug, it also means the programs. It also means the some of the procedures. It also means the human resource management also. So all these things, when they are taken together, we have many processes to go about the economic evaluation. There are many terms which are being used. So some of these terms which we learned in today's workshop. For your benefit, we have created a WhatsApp group, and we are keep on sharing all the resources which are there, which will be there in today's workshop, and also for the benefit of the general students also, for the country also, we have made it live on the YouTube as well as the Zoom. So anybody can join in the Zoom. We have not attending physically, although there are advantage of having physical attendance because this gives a more opportunity for networking, physical networking, and you can learn from the how they are talking and how they are speaking some few words which cannot be gathered on the online media. And we'll be sharing all other resources, and if you have any query or suggestions, you can also put in the WhatsApp group. If you have not registered or got into the WhatsApp group, you can make your name in this list. We are also trying to develop some of the process so that we can continue to hold help with you in the future also. And AIIMS Jodhpur can go into a more wider aspect of the health technology assessment. So with we have just planned for the 50 odd students who are really involved in the medical technology, but we are going to expand it for other people who are interested in that, even if they are not having any innovations or having idea. But I think health technology assessment has a very wider connotation. And this is a brainchild of Dr. Sumen Saha. He has suggested that why not our resource centers like IT Kanpur and IT Jodhpur, who are having these innovations in this area, they should be apprised of this health technology assessment through this workshop. So IT Kanpur conducted last month, and we are the second to conduct this type of workshop for the medical innovators. And definitely I can say that we are more privileged that we have more structured program at the back end, and we can take it to the forward to a more mature system. So with this, I welcome you all on behalf of AIIMS Jodhpur and IT Jodhpur and IIT Gandhinagar and HTA Delhi Center for this workshop. I will definitely, if you have any query, you can ask anytime or during the tea time or the lunch time. Thank you. Thank you all.
Thank you so much, sir, for your inspiring words and setting us such a great start. Before we begin today's workshop, I have a small request for all our participants. A pre-workshop assessment form has been shared on our WhatsApp group, HTA Innovation Workshop. I request everyone to kindly take few moments in between the session and according to your convenience and fill the form.
Thank you so much. Thank you so much, Pujita. That's perfect on for the workshop. So just before jumping into the sessions, first we know what is HTA, what is organizational structure. So we're now going to watch a short video regarding the introduction of health technology assessment, where you learn evaluation, organizational structure, distribution, and the functioning.
विंडो का स्क्रीन नीचे वीडियो के नीचे को आता है दो था और सर छोड़ो दूसरा
We take a few minutes. Sorry, guys. We have a technical glitch. After a few minutes, we restart the video.
Effectiveness of health technologies. Family Welfare has established the Office of Health Technology Assessment in India, HTA-IN. It provides an ecosystem for assessing the cost-effectiveness and clinical effectiveness of health technologies. It has a vast network of 6 resource hubs, 19 resource centers, and 10 technical partners spread across the country. It has provided more than 98 policy briefs with recommendations for central and state governments and published more than 272 research articles. It supports pricing and procurement, introduction of new health technologies, health programs, and revision of health benefit packages. For National Sickle Cell Anemia Mission, HTA-IN supported the procurement of point-of-care sickle cell screening diagnostic kits and reduced the price drastically. To prevent the spread of HIV and other diseases through unsafe use of syringes, state governments have procured safety-engineered syringes at negotiated prices. It also drives integration of new healthcare technologies like portable ECGs, neonatal hearing screening device, intracranial bleed detectors, telemedicine-enabled otoscopes, point-of-care tests for hemophilia, and color fundus photography for diabetic retinopathy. Thus, HTA-IN ensures cutting-edge solutions are accessible to people across the country. Contributing to Atmanirbhar Bharat, indigenously developed efficient health technologies are being promoted by HTA-IN. It has also supported national health programs like the National TB Elimination Program by facilitating the adoption of innovative treatments like BPAL-M for multi-drug resistant TB treatment, Psi-TB test for latent TB infection diagnosis, TrueNat for TB diagnosis, Teco Plus for tracking and managing TB health services, and AI-based interpretation tools for TB screening. One of the largest nationwide HTA-IN study resulted in price revision of Ayushman Bharat Pradhan Mantri Jan Arogya Yojana health benefit packages. Using cost data collected across 86 public and private hospitals, ensuring each intervention meets the highest standards of effectiveness and affordability. Building capacity in health technology assessment, HTA, with hands-on technical workshops and state sensitization meetings further ensures that HTA principles are integrated into regional health programs. HTA is a powerful tool in providing affordable, accessible, available, and quality health technologies for achieving Viksit Bharat. HTA-IN ensures that India is ready to face the challenges of tomorrow and protect the lives of billions. The Indian health
As we build the base on health technology assessment, how it's work, the structure, the function. Now it's a great time to start with our session. Our first sessions on HTA research question formulation using the PICO framework. It's my honor, it's my privilege to introduce our first keynote speaker, Professor and Principal Investigator, Resource Hub for HTA, IMPH Gandhinagar, expert in health financing, health system strengthening, and HTA, author of over 100 publications. It's our honor to invite Dr. Soman Sasar to kindly deliver the session.
Okay, very good morning. Thank you for being here. And as I was talking with Dr. Singh and Dr. Srivastav before the session started, what I understand here is that all of you represent innovators at different stages. Either you aspire to become an medtech innovators, particularly, or you are medtech startups. As I was told that there are 15 startups here commanding over 6 crore plus Indian rupees investment. So it is in that context, I thought I should talk about some of the dilemmas that you might have been facing, not in terms of raising resources, but in terms of adoptions of your technologies, startups that you have had in mind, and some of the dilemmas that you face at different stages. Dr. Singh has given an idea about what health technology assessment is, and you have seen two videos to talk about what HTA is. I will give you one simple examples of what HTA essentially end up doing. Say, for example, tuberculosis is an important condition in India. As you know that India is in the end game of ending tuberculosis. Of course, it looks like elusive. Now, for tuberculosis screening, chest X-ray is an important screening tool for TB case detections. Now, a standard chest X-ray would cost, let's say, 15 lakh rupees. And the sensitivity of the chest X-ray machine is 89. The problem with that is that you need a radiologist for interpretation of the chest X-ray. And we know that even if you have machine, having a radiologist is always a problem. At least in the state where I work in Gujarat, our community health centers, about 60%, 70%, there are vacancies of radiologists. So who will interpret it? Now, it is in that context, there is an innovation called handheld AI-enabled chest X-ray. Handheld means that it can be ported to the community, so people do not need to come to your facility, but the machine can be actually taken to the patient, and you can screen it and you get an interpretation of that X-ray. Now, this handheld machine, let's say, cost 500,000 rupees compared to 15 lakh rupees for the standard chest X-ray. So in simple word, you will say, adapt it, right? Because this is low cost, and low cost means cost effective. No. Now, the standard chest X-ray, the sensitivity is 89. That is, it can correctly detect 89 out of every 100 cases screened. This handheld machine can correctly detect, say, 62 out of every 100 cases screened. Now you are left with a catch. So you have one machine innovation which is low on cost, but also it is not able to detect all cases correctly. So what should you do? This is the question what HTA helps answer. This is one of the questions that HTA helps answer. That given the lower cost and lower sensitivity, does it still hold true for a country? In what context? The second type of question that HTA also helps you to do is not just saying that, okay, this innovation is cost effective, but if it has to be scaled up across all my CSCs of the country, across all my public health facilities, what would be the impact on budget? I'll give you one example here. So we were doing health technology assessment of adult immunizations for influenza vaccine. So immunizing 65 plus populations of the country on annual influenza vaccine. The vaccine was found to be cost effective, marginally cost effective. However, if you have to implement it at the rate where the manufacturers are giving to the state, it would take up a huge amount of the country's resources. So HTA also helps doing a budget impact analysis, that how much would it cost to implement it in one district in the entire nation. The third thing that HTA helps to do is a threshold analysis, that at the current level, cost level, this program would take up significant part of the budget. However, if the manufacturer is willing to reduce cost, and you would think, why should we reduce cost? We have spent so much time and resources. You will reduce cost because of scale. If your vaccine, which is currently available only in the private sector. Now, if the government of India adopt it, you will do it in scale, you produce in scale. So that is why you would reduce your cost. So at what cost the innovation or the new technologies would be cost effective? So these three things, cost effectiveness, budget impact analysis, and threshold analysis are primarily the three things that health technology assessment basically analyze. So that means that even for cost effectiveness, we need to have your clinical effectiveness data. Without that, we cannot work. Okay. Now, within this context, let's talk about. So you would think about topic, innovations, like you all have innovations, some ideas in mind. Either they are in TRL 1 to 3, or they might be in the messy middle, which is like the 4 to 6, or you must be in a stage of policy adoptions that is up from 7 to 9. You might, everybody here in this room might belong to either of those three different categories. So where does HTA comes and where do we fill? To understand this, I would also request you to go through National Health Research Policy 2026. This is not yet a public document, but maybe we all have access to it. It's for public consultation. So we will, I'll request Baldeep sir to basically share it in our WhatsApp group. Why? Because all the programs, all the innovations that you are talking with, it falls within the health research realm. All the medtech innovations that you are talking with falls within the health research realm. So to address this, Government of India has now come up in a document, Draft National Health Research Policy 2026. It is up for public consultations. I would encourage you to basically read it, because there you will see what value it has provided to health technology assessment. Health technology assessment, even now, it is in the recommendatory sphere. That means you have a technology, you think that, okay, you have got CDSC approval, you have got AERB approval, you have got all regulatory approval. Why is the state not procuring it? And you go to the state and ask the user departments, okay, this is a technology, I have got CDSC approvals. Please include it in your public procurement system. And many times you might hear, have you got HTA done? Okay, so that is where HTA is gradually, India still have it as a recommendation. HTA are recommending to the user department. But very soon we will move into a stage where it will be part of regulatory requirement that just like CDSU, you need to have HTA done for any technologies, any programs, any drugs, any diagnostic devices, if it has to be brought into the public procurement systems. Now, it is in that context, I would like to talk a little bit about topic prioritization and formulating PICO framework. These are the few things that I will talk about: identifying HTA topics, understanding systematic process of identifying public health topics which are relevant for HTA. We will talk specifically because I designed this when I was preparing for my IIT Kanpur workshops. Again, there also we talk with the innovators, and here also we are talking with innovators. So this is actually designed for you. That what are your frustrations? Why are my topics not being prioritized? We have submitted topics, but the topics are not getting prioritized. And we'll talk about that. Then we will see that which topics get prioritized. What are the prioritization criteria? What type of data you need to provide so that your topics get prioritized for HTA. And we'll see that how does it link to policy impact, recognize how a well-framed HTA question influence methodology, evidence generation, and policy uptake. And finally, we'll talk about formulating a good PI code. I hope you all know about what is a PI code. We'll just talk a little bit about that as we go forward. Now, this is, we talk about innovators' dilemma. We talk about first about what is Government of India or the state government's dilemma, where to invest. Okay, health spending comes at a cost of other priorities. If I have to invest in your particular innovations, I have to make a trade-off somewhere else. And how do I make that trade-offs? Okay, how do we decide where it goes? That's where the choice of topic is crucial. So first I need to decide whether your topic is important, and then I need to decide that whether that should be eligible for health technology assessment. A good HTA topic addresses a real health need. And you will think, okay, all my innovations that I'm thinking about are real. We are not doing something hypothetical. So why are you talking about real? Because the things might be real to you, but is it a policy priority? And how do we decide the policy priorities that we talk about? Feasibility to studying. Do we have enough data to conduct the study? Have you done the study? Does HTA means that you give me the device and okay, I have to do my to do clinical effectiveness, or does HTA come somewhere in after that? We'll talk about that, and produce results that decision makers can act upon. So HTA need to inform decision makers whether this technology, this product should be brought into the public procurement systems or not. That's precisely what the role of health technology assessment is. Now, prioritization. Now, in the prioritization matrix, as you can see here, your topics can be high of strategic importance to low strategic importance. Or in the x-axis, you see high resource availability, if I have a lot of resources, and if I have low resource availability. So if this topic falls in this first quadrant, which is high in strategic importance and low on resource availability, okay, then this become my strategic initiatives. If this is in that second quadrant, which is high on strategic importance and it needs a lot of resources to implement it, then it becomes critical project. Like say, we have our country's per capita GDP is about 2,500 Indian rupees. About, okay. Now, if your technology per procedural cost is say 500,000, then that means, and the technology is really important, so it falls as a critical project, which is high on importance and high on resource availability, need a lot of resources. So this becomes a critical project. And then it is high on resource availability and low strategic importance. So high resources and low importance, it becomes part of routine operations. And if it is both low resource availability and low strategic importance, then these are classified as non-essential tasks and hence not prioritized for health technology assessment or for policy adoptions. We cannot assess every health technology because even with all the resource hubs and resource centers that Dr. Singh talked about, Government of India need to still prioritize resources. If you do not have enough clinical information, clinical validation data, if you do not have regulatory approvals, if it is part of a routine procedures, then these are not classified for health technology assessment. We have limited resources, funding, time, and expertise, and government must decide to prioritize it. Remember, here when I talk about health technology assessment, I'm talking mostly from the perspective of public procurement system. I'm not talking about the private sector part for now. The innovation can originate from the private sector, but we are talking about adoption in the public procurement systems. So prioritization ensures that HTA focuses on the most critical needs and decision of the stakeholders. Now, how do I prioritize? How do we prioritize topics for health technology assessment? We look into burden of disease. First, we look into, is this critical? So example, cardiovascular diseases causes over 27% of total deaths in India. That is a high burden, high policy interest. If you're talking about tuberculosis, tuberculosis continues to have a high burden of disease. So this is prioritized for health technology assessment. Then we look into the policy alignment, whether it is linked with national health mission priorities. Does it fit into state health mission goals? Does it addresses some of the emerging threats or some of the unaddressed needs? We look into the equity dimension and feasibility considerations. We also look into vulnerable population. Are you talking about vulnerable population? Even rare diseases. A technology to address rare diseases can also be prioritized for health technology assessment if it addresses some of the vulnerable population, if it talks about rare diseases, and is this implementable? And also look into the service coverage gaps. For example, breast cancer screenings coverage remains under 10% in many states, as well as cervical cancer screening. So we talk about that in the video. You saw something about the cervical cancer, VIA, and other screening procedures, whether it should be brought into the public procurement system. So if it falls under this high burden of diseases, high service coverage gaps, it falls within the priority of national or the state health policies. If there is an equity feasibility, if you're talking about rare diseases, then your technologies, and do you have clinical data, then your conditions, your technologies, your programs, your devices, your drugs can be prioritized for health technology assessment. Now, I also happen to sit in the topic prioritization body, which is constituted by the Department of Health Research. So this slide I have made from some of the minutes of meetings, why we reject topics. As I said, that this slide, actually, this entire presentation is made for you as innovators, because we get a lot of topics from innovators. Why do we reject topics? I gave you some examples earlier, but some of the common reasons for rejections: insufficient clinical effectiveness, evidence, or immature technology. Many times we get innovators who would say, okay, what they send us are basically a flyer. And the flyer has okay, we have this technology, we have got ARB approval, we have got CDRC approval. They do not provide clinical effectiveness data, or they do not have it. They would say, okay, this is an idea. We have this idea. We're still validating it. Sometimes they do validate, but if you sit on the publication body, if you're an author of the publication, if you have funded that entire assessment, do I have the confidence that this assessment is right? Those are questionable. Your methodology may be right, but if you are the one innovator who has supported the study, if there is no third-party validation, if it is not supported through third-party, how do I get a confidence that your innovation, your data, clinical assessment data is right? This is one reason why most often we reject topics. In that context, here we do not have anybody from MedTech Mitra talking about, but I will briefly talk about that. ICMR has got a section called MedTech Mitra, designed for you all. What it does is basically, it is tasked to bridge the gap between innovation and adoption. So the clinical effectiveness, do not think always that you have to spend your own resources. You do need to have, you cannot produce spurious data and so the technology get rejected. But once you have some data from your clinical effectiveness, there is an ICMR, there is a portal called MedTech Mitra. You submit your product, don't submit it to HTA portal. I'll talk about that in a moment. First, submit your details to MedTech Mitra once you have secured your CDSC approval. MedTech Mitra will invest its own resources, not your resource, your money. It will invest its own resources. It will get a third-party validation of your technologies, of your product, of your devices at its own cost, at the cost of ICMR. It will validate it. And once it is validated, it will be sent to us, that is HTA. If you have got validation data, you don't need MedTech Mitra. You have got a third-party validation. You have implemented it. For example, you have done it with district hospitals. You have done it with other government institutions. And you think you have a robust data. You don't need MedTech Mitra. You have already invested it. So then you can send it to HTA portal. There is a portal for topic prioritization, topic submission. You can send it there, but do not submit data which does not have its clinical validation. And clinical validation, which is third-party validation and independent validations. Then your topic is likely to be rejected on the first round. No meaningful improvement in patient important outcomes over current practices. If there is no meaningful improvement based on the clinical data that you are showing here, then this topic is not prioritized for health technology assessment. If the burden of disease is not significant enough, then this topic does not get prioritized. Procurement-driven question rather than a policy or HTA question. If it is a simple procurement question, then also we do not prioritize those topics for health technology assessment. Comparator, target population, or intended use not clearly defined. You have given us a topic, but you have not told us about what are the comparators. Okay, what are the intended use of the product? If those things are not clear, it might be clear in your mind, but if you have not put in there, then those topics do not get prioritized. Technology specific details or validation data are missing. Again, linked to the first point. If you have not even just given us clinical effectiveness data, but you have not given us your details, you have not given us your CDSC approval, you have not given us information about your ARB approval if relevant, then those topics also do not get prioritized. Lack of India-specific implementation pathway or feasibility. You have got a technology, you have discovered that this technology is found to be effective in Australia. Let's say one example, mobile stroke unit, okay, which is an ambulatory stroke unit, which will transfer patients to a hospital, stroke-ready hospitals, and also provide the intermediate treatment protocol. Now, when the topic was taken up, we found that India data are not yet published. They are not out yet. The data what are available are from high income countries. Now, the conditions in those countries are very different from the condition in India. So then again, those topics do not get prioritized. Okay. Okay, this is about what doesn't get prioritized. Now the question is that, okay, so what should we do? Tell us something about that. So that's in the right part of it. How to improve chances of prioritization. Define a clear PICO and policy decisions. So talk about what is the relevance of your work, of your technology, of your devices. So you have to tell us what are the importance. Okay, why do you think this is important? Demonstrate an unmet need and health system impact. Provide robust clinical evidence. And the most robust clinical evidence, as you know, for those of you who may not know, in evidence synthesis pyramid, the most robust is meta-analysis. If you have got meta-analysis, provide us those data. If you do not have meta-analysis, then what? At least do an RCT, a proper RCT, which is peer-reviewed, published in Q1 journals. Provide us those informations. Specify your comparator, implementation pathway, and scale-up plan. Explain why an HTA is still needed. Why do you want an HTA to be done? You have got your CDSA approval. You can go about marketing your product. Why do you need an HTA here? So you have to explain it. Include budget impact and public health relevance. So what are the relevance of your product for overall public health? You have to explain it. Don't expect us to always understand. We do understand. We do have clinical expert. But you as an innovator, when you are submitting your topics for public procurement, you have to explain what are the relevance of it. Submit complete validations and regulatory information. Many times, innovators only, as I said, only give us their pamphlets. So that does not have any information about whether you have complied with regulatory requirements. Okay, so you have to give us those informations for us to decide whether your topic should be prioritized for an HTA study or not. So applying the topic selection criteria, first things, it shows decision makers awaiting evidence and supporting assessment. So any things that you have got this, this is high in the policy demand. If it fits right into the national health policy, then it is prioritized. If there is an evidence gap exists for the work that you are doing, that means that it reveals uncertainty about the interventions, urging assessment. So if you have got evidence, then you say that, oh, no, how does this evidence fill into the gap in the policy? Then that is prioritized. What if you have talk about economic significance, highlights high cost and resource misallocation and necessitate assessment. If it is technology is low on cost compared to the gold standard, but also provides reasonable effectiveness data, then those things are prioritized. And of course, if it is high in public health burden, like I said, tuberculosis, other diarrheal diseases, this is high on burden. Right now, we have this Chandipura case outbreak, which is going on. So these are high on burden. If your technology addresses some of this, or even rare diseases, which are routine, but rare diseases, but it's important for vulnerable population, those are prioritized. Feasibility, potential impact of the study. If you need to demonstrate it for applying your topic selection criteria. Example, HPV vaccines, should Gujarat expand HPV vaccination to all its adolescent girls? Now it fits burden, equity, and policy needs criteria. So it fits into that, okay? But the problem is that it would not fit if vaccine supply is unavailable or cost data is unobtainable. So while HPV vaccine for adolescent girls, this fits into the criteria, it's high on disease burden, but if some of these things are not applicable, like your vaccine supply chain is not robust enough, or you cannot obtain the cost data, then those things may not fit. So these are some of the considerations. So only having high on disease burden is not enough. So do you have a robust supply chain? Are you in a position to scale up? So what about the cost data? Are you willing to share with you the cost data for us? We have contacted innovators that we need cost data, and innovators says that we don't want to share our cost data. So then how can we do an assessment? How do we know whether it is feasible for Government of India? If you are not transparent enough to share your cost data, how can we get confidence in your work? Because once we produce a report and once the report gets approved by Medical Technology Assessment Board, it becomes part of government policy. So, and here, as you know, we do not take any money from you because we are funded by the government of India. So that is where we have a responsibility to ensure that whatever information we are producing for the country are actually valid, because then our credibility then otherwise is at stake. Another example, blood glucose monitor. A new expensive blood glucose monitor is proposed. It has a health impact. Diabetes is a major public health problem. It affects millions of populations. So basically, it's high on priority. Economic impact, the device is costly. It could increase the healthcare spending, but might reduce the long-term consequences. So a new monitor, a continuous monitor, a weekly doses. So those things are maybe costly. So remember, your intervention can be costly. But how do you justify whether it should be brought in public procurement if it improves the effectiveness? Then also they are prioritized. It is not necessary that your intervention should be less on cost. You can have a higher costly intervention, but does it have higher effectiveness? So that is where we make these decisions. The policy relevance, the government need to decide if it will be included in a public health program, high priority, and many times routinely we have procedures which are higher on cost, but also higher on effectiveness, which are prioritized for interventions. So what are the importance of HTA questions? HTA values comes from answering a specific questions. A vague question leads to unclear answers. So we always look forward that what is the research question that your innovation is trying to answer. If a vague questions does not provide a good answer, a strong question sets the foundations. It clarifies the scope, ensure that the study stay focused on their work, make it policy relevant, improves uptake. Decision makers can decide whether I should include this new device, new technology under my public procurement systems or not. To do that, we have this PICO framework. You probably are aware about the PICO framework, but for those of you who may not be, I'll just talk a little bit about it. So PICO is population, intervention, comparator, outcome, and time frame. So first, population, who is being studied. Then intervention, what is the intervention that I'm going to discuss? Then comparator, what is the alternative with which I am comparing it against? Is it my gold standard? Many times you will have a comparator which is not a gold standard. And we'll see handheld X-ray, for example. What would be the gold standard for handheld X-ray? Can some of my innovator friends, the medtech friends, basically enlighten me? Anyone who is working in the space of tuberculosis? Yeah. So if you're talking about handheld X-ray, what would be my comparator? Normal chest X-ray, right? Thank you. Is normal chest X-ray gold standard? Why? Because for even chest X-ray with the radiologist interpretation, the sensitivity is only 89%. That means for 89 out of every 100 cases detected. What is the gold standard then? Exactly. So culture-based test. So then, that is where the comparator comes. Your comparator, the traditional comparator may not be the gold standard, so you have to adjust it with the actual gold standard, which is a culture-based test, right? With MGIT, with NOT. So that is where when your gold standard is an imperfect gold standard, you'll have to adjust it with the actual gold standard for analysis. So that is where comparator, which seems to be a natural comparator, like a conventional chest X-ray, is not a gold standard actually. So you have to compare it with the gold standards in situation. And time frame, over which time, the time period, your outcome will be measured. Let's say influenza vaccine. Anybody who is working in the vaccine space? No one? So influenza vaccine, what should be the time frame for my analysis? Make a guess. Why? 2 years, 3 years, why? What will be the time frame of analysis? Time frame is not an efficacy of the vaccine, but basically influenza strain basically changes annually. So the time frame would not be more than 12 months. But if I say transcatheter aortic valve replacement, what would be the time frame? Until the patient is alive. So you have to look into the lifetime horizon of the patient. So likewise, your time frame depends upon the conditions for which you are doing the analysis. Very quickly again, population, you have to define the group of people, patient, problems being studied. Can be specific by age, gender, location, or condition of the patients. Okay. Example, children under 5 years in rural Gujarat, children under 5 years who are suffering from some specific conditions can be your also. So even it can be subgroup of the 5 years population. Importance, like you can say about children under 5 years who are severely malnourished. That can also become a subgroup. Important, ensure clarity about who benefits from the intervention. So your population has to be clarified. Interventions, the health program, treatment, or the technology being assessed. So that is basically the intervention. The program that you are basically sending us must be clearly defined and measurable. Example, HPV vaccine with 2 doses. Importance, it helps you to know exactly what is being evaluated. So it can be, the intervention can be in the space of drugs, devices, surgical interventions, service delivery models. It can be also public health programs. It can be diagnostics. So all these things. So HTA, in some sense, is a misnomer, right? Health, technology, assessment. So you think technology means only devices. It's not just devices. The HTA, the technology part of it includes all these things. It can include your drugs. It can include surgical intervention. It can include programs. A new program which may be brought into the public procurement system. Say, for example, home-based physiotherapy for stroke recovered cases, for stroke management. It's a program that can also be assessed for health technology assessment. The comparator, the alternative against which the intervention is compared, could be standard care, another interventions, or no intervention scenario. So if I talk about adult influenza vaccines, my comparator would be no vaccines. That means all the ILI cases will be managed either at the OPD level or at the ICU levels for severe cases. If I talk about tuberculosis screenings, so here the comparator can be chest X-ray, but with an imperfect gold standard, so you need to adjust it against the gold standards. Example, no vaccination or routine screening only. Importance, it provides a benchmark to judge or added value of your intervention. So comparator has to be defined for any assessment against compared to what? Because you are making a choice. You are making a choice whether handheld X-ray should be included in the public procurement system. The other alternative is conventional chest X-ray. You're making a choice whether transcatheter aortic valve replacement should be brought into the public procurement system. The comparator is surgical aortic valve replacement. You are making a choice whether GI stapler should be introduced. The comparator would be Hans Wins. Okay, so your comparator has to be very clearly defined. You're comparing it with against what? You're not trying to replace it, but comparing is still important. Why is this new technology? What is it trying to, where should we compare it against? If your comparator is not there, then yeah, it does not fall under the scope of full HTA. Outcome. The measurable effect of the intervention or the results you want to measure, it could include clinical, economic, and or quality of life. Now here in HTA, it's a bit tricky. What would be the outcome you would talk about? Say, for example, in tuberculosis screening, chest X-ray. I'm getting answer from here as well. So detection, still positives. If you're talking about transcatheter aortic valve replacements, bleeding, okay, relapse, readmissions. Now you see these outcomes are very different. Clinical measures are very different. That's what we are used to. So for HTA, that where should I invest? It depends also on your quality of life of the patient. So clinical outcome is important, must be reported. But for health technology assessment, we look into the utility matrix. which we call quality adjusted life years in utility matrix attached with every patient's reported outcome. With your clinical measure, mind it, your clinical measure must be reported for your assessment. But when we do go for HTA, we look into the utility matrix, which is called quality adjusted life year. I'll stop it there because that's not for you. That's for us to basically look into a quality adjusted life year. Just want to tell you, you might have heard this term quality adjusted life year or quali at different forms, and you would wonder, okay, do I need to report quali? No, you don't need to report quali. You report your clinical outcomes. We'll convert it into quali. We'll work with you to report it into quali. But that is important for decision-making purpose. Frames by the period over which the outcomes have to be measured. It can be, as we talked about it, it can be either the patient's life until the patient is alive, or it can be seasonal and annuals. It can be 12 months, it can be 6 months. If you're talking about peri-procedural, you might talk about 3 months period. So you have to define the time period over which your technology needs to be assessed or effective. So an example of PICO. So this is one question here. Population is adults with type 2 diabetics in district hospitals. Intervention is HbA1c point of care devices. The control here is lab-based HbA1c testings. So you are planning to bring in a point of care device for HbA1c diabetic screenings. The outcome would be glycemic control, cost per quality adjusted life year, and the time period here is 12 months. So an HTA question for it would be that in adults with type 2 diabetes managed at district hospital, who are the population here, does HbA1c point of care testing, that is intervention, compared with conventional laboratory-based HbA1c testing, that is the comparator, improve glycemic control and provide better cost effectiveness as measured as cost per quality, that is the outcome, over a 12 months period, which is the time period. So likewise, you have to give us the right question, that what is it intervention, who are the population, who are the outcome, or what is the comparator, what would be the outcome of measurements, and what for which time period you are looking in for. So to make it a good HTA question. The poor question is blood pressure screening good? It's a too vague a question. Lacks the population's comparator and time frame. But a good PICO example can be in adults with 50 plus at risk of cardiovascular disease. Does annual community-based blood pressure screening compared to no routine screenings reduces cardiovascular mortality and disability adjusted life year over a 5-year time period? This example from DeepCXS, so my colleague Dr. Dhaval will basically talk a little bit more details. So this is one study which we did where this is an AI interpretation of chest X-ray. This intervention was developed by an institute where Dr. Srivastava comes from, Ahmedabad. The IPR, Indian Plasma Research Institute, so they actually developed it and ICMR validated it. It's called DeepCXR. A deep tech innovation. So basically, we did an HTA of it. I'll skip this part because Dr. Dhaval will talk more details in a few minutes from now. But I'll give you another example. So this is from the TAVR study that we did, transcatheter aortic valve replacements. So here, the population is that adults with 65 plus a year with severe aortic stenosis in India. The intervention is transcatheter aortic valve replacement. The control group were surgical aortic or SAVR valve replacement, which was the current practices. Outcome would be peri-procedural. So here we're talking about outcomes and the time frame. So peri-procedural and long-term complications. Some outcomes can happen even immediately after procedure. So peri-procedural outcomes as well as long-term consequences in terms of mortality, relapse, morbidities, quality adjusted life year gain, and cost per quality adjusted life year. The time period here is 5 years period. So HTA question for this was framed as, in adults above 65 years with severe aortic stenosis in India, what is the comparative clinical effectiveness, safety, and cost effectiveness of TAVR, that is a transcatheter aortic valve replacement, compared to SAVR over a 5-year period in terms of peri-procedural and long-term complications, measured in terms of mortality, morbidity, quality gain, and cost per quality. So all those things have to be defined, friends, to move to technology assessment. I'll make one more point here. I do not have the slides now, but as I said that again, this is borrowed from NASA. We know what is the technology readiness level, and maybe somebody, Dr. Stevens or somebody else will talk about that. So where do HTA comes in? When should you apply for HTA? This must be a question in some of your minds. Anybody had an answer to it? By now you have figured out where do HTA comes in? Okay. Well, there does not HTA comes. I'm taking questions before I finish. So thank you. So first is from TRL 7 to 9. Yes, traditional HTAs, most of these things that you have seen here, we will take TRL 7 to 9. Why? Because we want from you is CSA approvals, any other regulatory approval. HTA does not replace regulatory approval. HTA comes after your regulatory approval. HTA does not do clinical validation of your study. HTA comes once you have reasonable clinical validation which has been published, then only we do HTA. These are the traditional HTA, 7 to 9. Then there is a newer concept called early HTA, which basically talks about TRL 1 to 3. So you have an idea, that is your ideation phase, right? So you have an idea and you really want to test whether this idea, if matured, can be something which would be of relevance to the nation. That is what is a concept called early HTA, TRL 1 to 3. Okay. So here it will be a more model-based HTA. You do not have clinical effectiveness data, but from different studies published elsewhere, from the model that you have planning, you want to understand that if this works, will it be relevant for the country? You know, at what cost I should basically look in for? What will be benchmark cost for my product? That is what is called early HTA. And then, what about the messy middle? TRL 4 to 6. So there is an growing but increasing body which are talking about this messy middle 4 to 6, which is where you have moved from idea, but you are at your testing phase and you want to basically understand that is it cost effective? What will be the budget impact? You have not yet looked into the level of CDSU. So, and in fact, this is something that we are going to do with the bank, with the World Bank at Haryana states on tuberculosis space, is with working with the messy middle, where you have moved from ideations, but you are in the validation phase of it. So it of course requires primary data collection because you do not have good clinical data. But this is where we have started working in the 4 to 6 domain. Okay, so HTA can come at every stages of your technologies. Just ensure that, and you are all here, I believe, from Jodhpur. You are in the right space where you have both IIT and AIMS hand-holding you in the process. So take the best use of it, and we hope that the technology which will mature from here, which are coming up, and even those who are maturing in the messy middles, in the ideations phase, this is the time where you can actually take the best use of the available mentors that you have with you to make products which are relevant for the country, can be adopted at a scale very soon with proper technological medicines. Thank you. I'll stop here. And if there are any questions we should take now or later, that would suggest. Okay, take it. Thank you.
Thank you so much, sir, for insightful presentation. Let us know about how HTA help in budget analysis, threshold analysis, and how PICOT help us to effect our study move. So I now request Dr. Kuldeep Singh sir to kindly felicitate eminent speaker with the momentum. Please round of applause, please guys.
Ladies and gentlemen, now I kindly request everyone to gather for group photos. Once the group photo is completed, we will proceed with the tea break. I request everyone to please join us for the photograph. Also, we have feedback standing on the left side. I encourage everyone to take a moment to share your valuable feedback and your experience. Thank you.
We have to gather at the front. Please, all the participants, everybody, please gather for the photo, group photo.
I'm requesting everyone to kindly reassemble in the hall by 11:50 a.m. as we continue with the remaining sections. Thank you.
दिखना मत सामने
पता भी नहीं चल रहा था।
इतना ऐसे सांस चल रही है पानी की ठंडा
कुछ नहीं हो रहा।
अब चाय पियो दोस्तों ये चाहिए बढ़िया
स्पेशल है सो।
बादाम में जूस
एमबीएस पेड होता था, एमबीएस वाले की दिक्कत आएगी। तो गूगल सॉफ्टवेयर और उसको बस इसलिए एक डुप्लीकेट रिमूव करने के बाद मेरे पास अच्छे आर्टिकल्स बचे। टॉपिक ऐसा Yeah, what for?
हाँ हाँ bro.
innovation in public health program. It's my honor to invite scientist D. Isemar DHR, hold PhD from Sweden, advanced training from Harvard, author over 160 international research publications, and big recognized top 5% scientists worldwide. And he recently received Silver Award for Research Excellence in 2025. I honor to invite Dr. Krishna Sahu sir to kindly deliver the virtual session. Over to you, sir.
Yeah. Thank you. Am I audible and my slide is visible, PPT?
Yes, sir, you are audible also, and the slide is also visible.
Okay. Thank you. Before me, Dr. Singh and Dr. Shah briefly introduce about the need for health technology assessment and what type of clinical evidence is essential. Now we'll discuss about the evidence required for adaptation of medical innovation in public health program. Uh, Let us start with a quote by Subramaniam Chandrasekhar. I am aware of the usefulness of science to society and of the benefit society derive from it. That means whatever science we are doing, ultimately it should be benefit from for the public. But when you think about the pathway of science to adoptions or implementations, there are a lot of steps. First, in science, we assess organization, process, methods, disseminate. Then we develop the policy. We appraise and we take decision. Then after that, that policy, then it will be go to the population level impact or decision making. So science, policy, and the impact in population is linked to each others. Uh, but the problem is that and HTA is bridging the gap between evidence and policy making and the its support for the implementations at the population level. But if you see the wild evidence, always there is a gap between the knowledge to practice. So it takes huge number of effort to convert the knowledge into practice. If you think how many number of research publication we have, but how many of them are translated into real practice? So it takes 17 years to turn 14% of research into day-to-day clinical practice. The study conducted in 2000, they say that it takes long time to translate. That means it is very hard to translate the science into policy and practice, but which is very necessary. That means always there is a gap between the what we know and what we practice, and the scientific study of methods to promote systematic uptake and evidence-based practice into routine practice. Evidence-based practice, what we are doing today, we are discussing about evidence-based practice, but how to convert this evidence practice into routine practice. Hence, then we can improve the quality of healthcare. So if you see, previously we discussed where does Dr. Shaha, when he present and discuss, where does it HTA stand? So when we are doing any technology or a device development of any device, we are seeing can it work. That means we are testing in a control environment in your laboratory, data taking, or whatever the randomized control trial study you can do. So these all are conducted in a laboratory setting or a control environment. So then you are generating the data and efficacy. Can it work? But when you think that does it work in reality? Suppose you devise a medical device using the AI based technology, and you claim that it could be we can let us say that one technology cough sound means detection of tuberculosis using cough sound. Okay, when you develop this technology, you prove it and it has a very good efficacy in your laboratory conditions. You took lot of data the controlled environment. But when you want to implement it, but we should think that does it work in reality? Can you take to the community, and in community what are the other factor affecting it, or it is give the correct result or not? That is called effectiveness result. After this efficacy and effectiveness result, it is not necessary that we can implement all technology. Is it worth doing compared to other things that could do with the same money? That means already we have a lot of standard of care, lot of practice is there. They are doing already. We have already invested money for that. But is it worth to just replace that and again introduce one new technology? Then we can call it as a efficiency, that is cost effectiveness. So these three key terminology are very important. Efficacy, can it work, that is in laboratory environment where basically we do the clinical trial. Then does it work in reality? Effectiveness, where do implementation research, we take that instrument or that intervention to the community and we generate some data along with some feasibility data. And then HTA, cost effectiveness, once it work in reality, then for the large scale implementation for the public procurement, we'll see its cost effectiveness or efficiency, that there the health technology plays. So if you see the integration of HTA into decision framework, where the HTA stands, first already the previous speaker talked about the approval. What about the technology you are doing? The first point is that approval, and they give approval based on the safe and effectiveness. Can it work? Can it work? Then then you compare the favorable to other therapeutic options, that comparative effectiveness research. You do some comparative effectiveness research, means how my device, my technology is working as like other for the similar diagnosis or screening. Then you present a good value for money, then you do cost effectiveness analysis. This is all are in the optimal actions. Even HTA do all are in the optimal actions. So after that we ensure the uptake, where we think that maximum benefit, means we prescribed appropriately, adhere to over the long term, so that then we can do some implementation research. So these are the place where we can fit HTA in your from technology development, approval to the adoption process. So same way as for the WHO, first thing is it safe and good quality, which is basically judged by the regulatory approval in our context CDSCO. Then regulation is important. Then can it work in my country? Do we really need it? Appropriateness. Then how can we use it effectively? Where the HTA play good key role. So, but the thing is that many times many innovator came to us and give the topic for us. But when we assess that, we found some data gap. What Dr. Shaha already discussed this in his session. So what are let us will today focus only for the diagnostic accuracy study or technology, medical technology. To conduct a HTA, there are five major type of data requirement is there. One is clinical effectiveness and safety, cost of health services, epidemiological data, and demographic data is very important. What is the burden of disease, who are the population suffering? So these are the very important data for calculation of economic model. scheduling and as well as for the budget impact analysis. Then service utilization, that means clinical pathway, understanding the clinical pathway. Many times see the developer, those who are working, they are not consult with the clinician. So it is a very good platform. AIMS and IIT Jodhpur, they are organizing together. So that means it is a very nice integration. So many times we discover or we invented some new technology, but we don't know the real utilization of the technology, how it will be fit. So before that, you should understand the clinical pathway, the need of that technology, how it could provide better quality result in comparison to the current practice or standard of care. Then we need also quality of life data. So but today we'll be more focused on the diagnostic accuracy, matching the result of proposed health tech with the gold standard or reference standard. So let us consider all these technology into health tech. So NICE UK defined health tech as the broad set of technology that support healthcare delivery, including digital health tool, medical device, diagnostic, related information technology. It works for prevention, diagnosis, treatment, and monitoring. In overall, it enhances the health system efficiency. So we will be use the term health tech. What is the evidence development pathway? Evidence development pathway. So in the evidence development pathway, first you discover the inventions, that potential value propositions. No, you consult the stakeholder engagement, barrier and facilitator. I think some noise is coming. Someone is, you can mute someone. Hello? There is some noise coming. Can you mute?
HTA वाला login कैसे करा यार तुमने?
Hello?
जाहिद जाहिद
Hello? Uh, am I audible now?
Yes, sir,
Amit?
audible. Yes, sir, audible.
Yes, some noise coming, no, that's why. So now let us discuss about the evidence development pathway. So when you are developing this in your technology, first you discover the discover or inventions, then potential value proposition is very important. I don't know how many of you are prioritizing this. So when you are put the potential value propositions for the device, you look the most stakeholder engagement to understand the barrier, facilitator and market access and adoption, also all the things. You do consult with the clinician, you do consult with the program people, you do consult with the community members and all type of stakeholder you consult before designing a instrument. Then you plan out to the need, societal need, that is called scoping the things. And then you also see what the standard care is there and what are the challenge and cost associated with the standard of care. Then you design your technology in the laboratory conditions, that is called analytical validity, laboratory performance. So once the laboratory performance is there, many times this does the test work in the laboratory condition, analytical validity. Many times you know that this AI based technology, when they are coming for the HTA, they have diagnostic accuracy data, but it is in a control setting or laboratory performance when they're developing their model. But that is not is really useful for to prove is it give good clinical performance or not. It should be validated in the real world. That is called clinical validity. Does the test work in the patient population of interest, also called diagnostic accuracy study? Then we need diagnostic accuracy study. Then after we'll see the value. Value means clinical utility. That's why we are doing cost effectiveness analysis, or HTA. Is the test useful? Can it lead to improvement in the health outcomes? So this is whole care pathway. Then Dr. Shah what discussed, we can sometimes do early economic modeling. Then we can do cost effectiveness analysis. Then we think about the adoptions, that is actual value propositions, potential value proposition to actual value proposition. This is very important for the technology development to adoptions. That means it is an integrated approach. We should move from silos to systemic approach. That we cannot work in a isolations. We should know technology developer, can't claim that I am a IIT, I am a technical person, so I should not communicate with the doctor, I should not know that, or doctor can that. Now for Viksit Bharat, it is very important to work together. Instead of working in isolations, we do some systematic approach wherever the necessary. We should go out to field. I wonder sometimes how many innovators are going to the field to understand the reality. If you really understand the problem and design your technology accordingly, validate it in the real world setting, then the adoptions of that technology become easy. Okay, so let us see that what is a diagnostic studies, how or clinical validity studies. Once you develop the technology in your laboratory conditions, then you prove it in the patient how it working. For example, let us see that malaria test. So the gold standard for malaria test is that microscopy or blood smear. Gold standards we consider, like tuberculosis we can consider also. So this microscopy is the gold standard. Now that the many rapid diagnostic kits are there, this is all called index test. For example, today one kit is there, histidine rich protein 2 HRP2 test is there. You people are developed this. Then tomorrow another kit came also, PLDH test. Another kit called 5-flex. These all new kits are come. They went to the policy maker or stakeholders or hospitals or state. Okay, you can use our kit in your malaria program. But how the user, how the service provider, user department trust on your technology without getting the proper evidence? So you have to prove how your technology is giving a result in comparison with the gold standard, reference standard. That's why Dr. Saha emphasized a lot on his lecture regarding the PICO, population intervention comparator and outcomes. But in this case, in the diagnostic accuracy study, the PICO population is same in HTA and diagnostic accuracy study. Then intervention is the same, the new technology, new device, but the comparator is different. In the HTA, comparator is the current standard of care or standard of practice. But when you do any diagnostic study, the comparator is the gold standard. What is the gold standard or reference standard available? So then you have to do field validity test. Even during the analytical validity also, you should test your result with the reference standard or gold standard. So when you do this test, what is the classical method evaluating the diagnostic accuracy study? Let us consider example, if your test result is dichotomous or binary, yes or no. Yes, I know that some of the disease like hemoglobinometer, if you take hemoglobin, would be not give anemia or not anemia or severe, mild, moderate. You have to classify. You will be get the decimal value, then you have to classify as per the standard guideline. But let us consider it in a dichotomous. If the result all participant in the study, then what is your new test or index test? that all participants undergone the new test and the gold standard simultaneously within a short interval to avoid change in the disease status. Means same day you can test with your new device, you can test with the gold standard. Then you match your result of gold standard with the index test. Here is the new index test. Suppose gold standard have positive and negative, index tests are positive and negative. Then you say if the gold standard give positive and your test is also give positive, that is true positive. That means correctly your device is correctly detecting the positive cases. Similarly, if the gold standard is giving negative result and your device is giving negative result, that is true negative. That means your device detecting the true negative cases. किसी का disease नहीं है, correctly detect कर रहा है. But the two point is sometimes the result differ. Means the gold standard is saying there is no disease, but your device is saying yes, disease is there, or vice versa. So that is called false positive and false negative, where we cannot correctly detect the disease. Based on this result, your device sensitivity and specificity, that is called diagnostic accuracy of a device, is calculated. So index test is a new test under evaluation. Reference standard or gold standard is the test employed as the benchmark to evaluate the index test with sensitivity and specificity equal to 100%. We are assuming that is the gold standard, benchmark standard available. Then the basic measurement we are doing sensitivity, that means the proportion of the participant correctly identified by the index test as having the target conditions. This means those with the disease. And specificity, the proportion of participant correctly identify the index test as not having the target conditions. Similarly, another two measurement is there: positive predictive value, negative predictive value is there, but basically we focus on the sensitivity and specificity. So based on this true positive and true negative, you calculate the total percentage of correct test result, that is called accuracy of your device. So that result must be valid, but many times we found the study, clinical validation study, the population is not appropriate. If you intend to implement your device in clinic in community setting, your clinical validation should be community setting. You clinical validate your device in a hospital based setting, and you are saying that adoption in the community setting. So you must generate the evidence in the community setting. Sometimes they don't have a good gold standard. They compare with another device which have the already used in the standard care, that is standard of care, or that is another index test. So you cannot compare your one index test with another index test. So you have to compare with the gold standard. So in that case, it is very difficult. Sometimes we feel very bad also for the innovator. Okay, they put lot of effort and they publish the paper, but what the published paper is not giving the proper evidence for the adoption of the technology, because their population is wrong population, their gold standard or reference standard is not correctly chosen. Even sample size also calculation is very important, how many sample you need. So these are the things we are not taking care when are developing the technology. I think if I economically calculate from the technology development, we spend huge amount in crore. But if you actually speaking truly, the clinical validations study, it takes very less amount. If you have a good collaboration, then only HR and machine device cost and the gold standard test cost is essential. It is in lakhs. You can, and the sample size is just 100, 200 or 300 based on the disease conditions, based on the prevalence of that disease in the community. so it not take more test, but they came to us with this that they say that okay, the CDSCO approval is there, then we must need HTA, but CDSCO says that it can work, but when you say it should work, then you need proper clinical evidence, because once the HTA we conducted and recommended to the state they use, if your technology is not working, then what will be happen? They invested a lot of money. So robust. And another thing also, many times the innovator conducted the clinical validation study, they are very much interested to be part of the author in that study. I don't think so. It degraded the means the publications value, like it should be third party. You or should be validated it, you should not part of that. Yes, you can go provide training to them, the staffs, you could provide your machine instrument or device to that staffs, but you should not be part of the study in a author or while conducting the study, because it should be biased in the result. So this standard of care is very important, and this key message we want to provide the whole the innovator, that yes, once your technology is developed and if, once you get the CSCO approval, do some good clinical validation study with proper design and chem for the HTA, and that is very useful. So this is just example we how we calculate the sensitivity, specificity, what negative predictive value, positive predictive value. Here new device is the index test, and the gold standard is the reference. So why it is problem false negative and false positive? So false negative means the test doesn't detect a condition when it is actually present. Okay, this is scientifically or medically, but if you think social impact, एक कोई आदमी का डिजीज है, आप बोल दिया आपका डिजीज नहीं है, test doesn't detect a condition when it is actually present. So what the societal consequence for this? एक किसी का डिजीज है, आपका इंस्ट्रूमेंट बोल रहा है आपका डिजीज नहीं है, so it will become severity, it become early, enhance the morbidity and mortality, and if it is an infectious disease like TB and other COVID and or other viral infection, it will be spread in the society. Second part is that sometimes false positive test detect a condition when it is actually absent. It has also okay, biologically or medically you can say okay, ये तो disease नहीं था, ये नहीं हुआ, but what is the societal impact? Because science is always made for the society. So in that case, you see, you will be refer again for the further referral test, out of pocket expenditure, family accompanying, lot of things. And also मैं आपको अगर बोलूँगा आपका पास ट्यूबरकुलोसिस रियली नहीं है, मैं बोल गया आपको ट्यूबरकुलोसिस हो गया, आपको ये डिजीज हो गया, then it will be give also psychosocial stress. So that's why its correct detection is very important. Then why you think that you saying that we are spending 5 years, 7 years from this instrument, you spend huge amount of money. Why and CDSCO also give regulatory approval. Why HTA will not assess your study? Why HTA is saying there is lack of clinical evidence? But you realize the things. It will be also not only if your device have not proper standard clinical validation result, then it not only affect to the patient by providing the false negative or false positive result, it also a big loss to the health system, because when public procurement, we are investing some money and in a large scales, it's a huge budgetary implication. That's why any study before HTA, before public adaptations, definitely robust clinical evidence, clinical validation is essential. Yes, that's why ICMR, DHR is supporting the innovator to MedTech Mitra, to Patent Mitra, to generate the clinical evidence. We support the indigenous technology. We definitely encourage the indigenous technology. But you think as an innovator, if we don't have this result, what will be happen to the patient as well as society? So these are some formula how we calculate the sensitivity, specificity, this value. So this is not important. Let us consider another point. Sometimes there is no gold standard is there. Yes, if no gold standard is there, you can discuss with the clinician which is the gold standard for this disease. If there is no gold standard, then there is a paper in it published in plus one in 2019. This a systematic review. They provide a flow diagram. Is there a gold standard to evaluate the index test? If yes, are participants verified with the gold standard? Yes, use a classical method for diagnostic accuracy study. If there is no gold standard, is the diagnostic accuracy of imperfect or reference standard known? Another imperfect or another standard is there. If yes, then consider the correction method. So if no, then can multiple tests be employed to evaluate the index test? So this flow diagram is there, so you can follow, but you must consult with the clinician. What is the gold standard? What is the current standard of where I want to deploy my device? But many times the innovator should also understand the clinical pathway or care pathway of the disease. Then only he could properly suggest where my instrument will be deployed. Okay, so these are the steps to designing a diagnostic accuracy study. You develop a protocol, selection of the participant from the target population. Who is my target population? Then selection of appropriate reference or gold standard, sample size, how many sample I need, selection of accuracy measure to estimate what are the measures I will estimate. It is binary or continuous. If it is continuous outcome, what standard of classification I will use for my to calculate the sensitivity and specificity. Okay, so then validate result should be reproducibly strength and mention what are the limitation and strength. Because when we are doing HTA, our research center and the team, we're searching for the robust clinical evidence. If you have robust clinical evidence, then nobody can stop you from the adoption of the technology. So this is all about that. Then I briefly, within 2 minutes, I can say that HTIN ecosystem. So previously in 60, more than 60 countries already implemented HTA, and in India in 2017 in under National Health Policy, HTA started. Then HTA Health Technology Assessment in India was established under DHR as a project. Then 2020 the Parliamentary Standing Committee working group who recommended establish of a HTA center as a scheme. Then June 2001 it becomes sub scheme. Then 2023 it become attached office like NHA, National Health Authority. It is become a attached office, and recently also last year Honorable President passed the rule for the HTA as a business amendment rule of DHR. So we are in during the last decades the HTIN now many like Dr. Saha told that now not only the CDSCO approval, many state and many user department, central user department, they also ask you to either your technology is validated, it's HTA assessed, but you submit your portal, you don't have the enough. Our team is guiding you properly what type of evidence is essential. But my point is, once your technology is ready and do some good clinical evidence and collaborate with the nearest medical center, or in Jodhpur also we have another ICMR NIHR National Institute of Health Research, where we open another center for the adoption of the technology. Recently it was opened, and AIIMS Jodhpur also the HTN center, you collaborate with them, they can suggest you what type of data essentials support. I think you feel so lucky that okay, once your technology ready, what type of data required for the public adaptation, they will be guiding. And we have 7 research hub, 22 regional research center, 5 adapt center and technical partner. That means across India, all part of the HTN cover. So we have many user department, all the government department, and we open innovator portal to submit the proposals. And we have it is a very robust assessment. When topic come, we'll prioritize the topic, see the clinical evidence, regulatory approval, and where it will be fit in the pathway, clinical pathway. Then we'll assign the topic to one of our technical in a resource center. Then that will be come to the again technical appraisal committee proposal. Then the proposal will be approved. Then the study conducted by the research center. Then the outcome report will become, once the outcome report is approved by the technical appraisal committee, then it will be go to the high level MTAF medical technology board for the policy. Then we will be develop a policy brief, and we share the policy brief to the for the public domain. You can get all the policy brief in our website, and that also we also disseminate with the all state level stakeholder. That means if your technology is once have assessed by the HTN team, not only you emphasize you for adaptation of technology, we support them and we discuss with the state through our adopt center to implementation of the technology. But before this information of robust clinical evidence is very important. Cost you can reduce, but it is very difficult to provide a good clinical evidence. Cost you can reduce, you can increase. Based on that, today only 10 machines. If government of India want 3,000, 4,000 or 1 lakh machine, then automatically the cost will be reduced. But what about the clinical evidence? We are doing the HTA is not for the technology, but it is doing for price and procurement, support health program, and also National Health Authority health benefit package, AVPMGI package also we are supporting. Finally, I can end with my talk. All the ideas are useful unless used. The proof of their value is in their implementation. Until then, they are in the limbo. So, all technology, all science, everything should be implemented, should be benefit for the society at the end. Thank you. Hello, Amit. You are not audible.
Now I'm audible, sir.
Yes, you are audible now.
Thank you, sir, for insightful presentation. Any queries from participant sides? Any doubts? Please feel free to ask. It's a great opportunity. From backside, any questions? Okay, thank you, sir.
Thank you.
So, before moving to forward other sessions, Soman sir, we have some questions. So please answer that question. How do we find a comparator for a global gold standard technology? Alternate option do not have such sensitivity and specificity.
Is the question from
The online.
So this question is not very clear to me. I think it is Alok from MedTech, if I can read it. If you can explain the question a little bit more. I'll just, because this to me is not a very clear, you can give a specific example, maybe I can answer that, but I will still give you some insights generally.
I think he want to ask if gold standard does not having any sensitivity or specificity.
No,
What we have to-
so that is not possible because the term gold standard is used when basically it has been validated. Otherwise, it will not have used. Like, for example, I give you example of chest X-ray. So if you are comparing a handheld or an AI chest X-ray, you compare it with conventional chest X-ray. But the conventional chest X-ray is not a gold standard. Its sensitivity is only for 89%. So in that situation, so basically you compare it with the culture, MGIT or not, because those are the gold standards. And you further modify it with the based on the gold standard to do your comparison. In certain situations, you may not have evidence from India, if that is what we are talking about here. This example is a transcatheter aortic valve replacement procedure. There, because as I have also discussed during the break with some of you, the evidence pyramid meta-analysis will be considered as the iron evidence. So, but clearly here, compared to Scandinavia, there are partner trials which are done globally, and that is considered as a gold standard of evidence. So, we took those trial data, the meta-analysis data, global evidence data, as clinical patient and compare the cost with what is reported under CGA. The CGA is not the public sector, but there are institutes like AIMS and other institutes which are okay doing TAVR of clinical practice. So we took the rates of the procedures, rates of the work from CGHS data to do their comparisons. If Alok could further explain those questions in what exactly he meant to, then I could, I'm a better position to answer them. Thank you.
Any questions from sir's lecture, if you want to ask? Yes, sir. So, like, jump into next session. You have that pre-questionnaire. You also fill that form as well. You have any doubt from that form? Any doubt? Any queries?
Okay. Moving on to our next section is on economic evaluation of health technologies case study. May I invite Dr. Naval Parmar sir, Senior Health Economist, Resource Hub HTA IPH Gandhinagar, with expertise in health technology assessment, economic evaluation, and antimicrobial resistance, and over 13 years of experience, to kindly deliver the session. We look forward to most insightful presentation. Thank you. Over to you, sir.
Thank you. So, till time we had already learned what is HTA and how research question can be found, what is PICO, and what kind of diagnostic accuracy or what kind of evidence are required to proceed for an health technology assessment of your innovation. Right. So, I will let you walk through our case study, which we had done at IIPHG, that is Deep CXR, and we'll visit the how we had concluded the study and what kind of data we had used. So, every health technology assessment starts with a problem. Fine. So chest X-ray is there in TB diagnosis case care. Fine. And with chest X-ray, there are three problems. One is radiologist shortage, delay in interpretation, and third one is the interpretation inconsistency. Means readers are not consistent. Results are not consistent between the readers. So to overcome this problem, Deep CXR was developed by the IPR, Institute of Plasma Research, Gandhinagar, and that software provides the interpretation on behalf of a radiologist. And this study was allotted to IPS Gandhinagar. So basically, it's a software which is interpreting chest X-rays on behalf of radiologists. Now, what our comparator would be? Radiologist, fine. So this is the PICO framework, what we had used. Population, our presumptive TB cases, TB patients. Intervention is deep CXR and comparator is radiologist interpreted chest X-rays. Most important diagnostic outcomes. What we had focused is sensitivity and specificity, along with true positives, true negatives, false positive and false negatives. Whereas economic outcomes, screening cost per X-ray, cost per correctly diagnosed case, and incremental cost effectiveness ratio, ISR. Right? So this is the most important PICO framework, which is again will be utilized for the economic evaluation. So every single row is having it requires some data, which is again will be used in modeling. And what kind of model we had proposed at that moment was this. So every patient who is presumptive for TB will go either to the deep CXR pathway or to the conventional digital X-ray, which is again being interpreted by radiologist. Fine. And again, that patient is having two chances. Either it would be screen positive or screen negative. But ultimately, it would be diagnosed with whether it would be a true positive, true negative, false positive, or false negative. So this is the decision analytic model which was used for deep CXR assessment. Fine. And each of this block needs some data. So at that moment, what kind of data was required? So if we talk about clinical effectiveness, then first is the diagnostic performance. How good the deep CXR is, that whatever sensitivity and specificity it is providing, it can be judged by that. But say for example, just as Anna bataya, if someone says my innovation is very good, it is 90% sensitive and 90% specific, it provides specificity, then whether it could be adopted directly. If it is providing maximum 90% of sensitivity and maximum of 90% specificity, whether it would be eligible to get it adopted? No. Fine. So for our model, if you remember, we also need the diagnostic classification too. Just sensitivity and specificity not work. We need more detailed data, that is what 2x2 table, contingency table would be required, which will again represents true positive, true negative, false positive, and false negative. Fine. Then reference standard. In this case, our prime reference standard is radiologist, right? Against which we are comparing our innovation, that is deep CXR. And second would be the microbiological confirmation, that is MGIT or culture. Fine. Then population parameters, what kind of prevalence of disease is there, distribution of TB and non-TB cases, clinical pathway inputs, how this, at which place this innovation is going to be placed in diagnostic pathway, at what portion it will be required, follow-up and confirmatory tests. After screening, it would definitely go for confirmation. तो पूरा पांचवा वहां पे डिस्प्ले होना चाहिए. And so each clinical evidence is again a basic requirement, and that is the data. At every point we are asking for the data, right? So from where we got those data? So as Somen sir had already mentioned, key RCT is the primary source for any of the data. So in this case, deep CXR was validated by ICMR itself, and it is having a data set of almost 14,000 chest X-rays. from 12 Indian states. Fine, so it was a very huge data. And again, it was validated by ICMR, so there is no doubt in the quality. So we had adopted that primary data, validation data for our study. Afterwards, it is not that the single source would be there and it would be enough for the HTA. We also have to rely on secondary data to fulfill all these gaps. So minor gaps would be fulfilled by the secondary literature. Okay. Then programmatic data, national TB elevation data was also used just for the diagnostic pathway calculations. And cost data, we had also approached micro costing data where we had considered the hardware, software cost, implementation and training cost, maintenance and operational cost. All these things would be considered. It is not that key your device is costing X amount would be considered directly. So apart from the cost of that device, many costs are there that will include implementation, training, maintenance, and operational. Fine. So this is the final HTA roadmap, evidence roadmap. So basically, intervention performance, whatever your intervention is there, you must have to provide the evidence. Yes. So primary data was at that moment it was not published, but again we had got from the ICMR itself. We had asked for the data that we are conducting health technology assessment of this DeepCXR, and you had already conducted the validation when we required the data. So as it was from the ICMR, we have to trust that, and we had completed the study. By the time recently, just before 2 months, it got published in IJMR. So, and again, it was peer reviewed by their scientists also. But again, it is not required that we always have to prefer primary data only. We can also go for secondary itself. If meta-analysis is there, rightly mentioned by Somen sir, that if systematic review and meta-analysis is there, then we can directly adapt that. But again, it would be of your technology and not of others. It would be representative of your personal potential technology or whatever intervention you are proposing. Fine. So mainly you have to prove that your intervention, whatever you are proposing, is efficient, and that efficiency would be assessed by providing the intervention performance. It could be sensitivity, specificity, and any of this. Then population epidemiology, we are focused. What our intervention is focusing on desired population that would be proved. Again, comparator. When we are assessing our technology, there must be a comparator or the existing infrastructure. By proposing our intervention, we are going to replace that. So again, we have to have one gold standard or a comparator. The implementation feasibility. Again, it would be feasible. It would be implementation. It can be easily implementable. And cost and resources data. Fine. So we usually have to focus on such kind of data before going for an HTA. So I would like to end this session with a small suggestion that many of the HTA, many of the innovators usually focuses on how good they can make their innovation. But alongside, they have to focus that how best they can develop some database especially to their innovation that could be used as a backup for adoption part. Because HTA is just not proving the worth that intervention is working properly. But again, HTA is also proving that your innovation is value to the patient as well as health system itself. Fine. And for that, data is the key. So you have to start, if you are starting from today itself, then you must have to focus on the data part also. Fine. Thank you.
Thank you so much for such a valuable and enlightening presentation. I would now request participants to ask their questions or any doubts regarding this session. Okay. Moving forward, may I request Dr. Kuldeep Singh sir to kindly felicitate our esteemed speaker with a memento as a token of gratitude and appreciation. Moving forward to our next session, which is on designing health technologies with meet healthcare needs, perspective of engineers and clinicians. May I invite Dr. Siddharth Shrestha sir, Professor of Practice, IIT Jodhpur, Protein and Precision Oncology, Medical Cell Imaging Analysis, to kindly deliver the session. Over to you, sir.
You have taken a lot of knowledge till now. Along with that, you were doing something also. So, I had prepared a brief presentation which would have told Dr. Somin about our program, how exactly HTA and our program would merge. But while, listening to all the discussions, actually, I have more questions. So I feel that maybe I should ask those questions, and if you can give one of the microphones to Dr. Somin. And I would like to put the perspective on the innovators. And from the innovators' perspective, I would like to ask questions to you. And then if the time permits, then I'll tell you more about what our program stands for, and then you can think of how HTA. If you would like to do an HTA clinic with our innovators, like one-on-one hand holding and telling them, what they can do. So one of the things what I observed or what I'm gathering is, looks like HTA is created by policymakers because they had a problem. These are my citizens, right? They had a problem that they had technologies. They didn't know like how to assess these technologies, how to purchase them. Maybe they should not get into any accusations that okay, I gave contract to this technology and now I am in trouble because there are questions on me. So a policymaker out of his own or her own need created this HTA, but for an innovator, it's a big problem. Because, as Neha told you, while there was this discussion that the innovator is already investing so much time and energy just to go and deep tech innovator. I mean, they are already stretched thin. They don't have money. They have to,
Voice is not clear.
Build innovations, etc. And along with that, now you are saying that, okay, jump the hoops of HTA. So I would like to have your comments.
Yeah, so thank you, Dr. Srivastava. So I can't completely understand. So whether HTA came from policymakers, answer is probably yes. Why did they came from policymakers? Because so before HTA, how we decision? Have a new drug, have a device. You think that this is something that government should adopt? How were decisions made? You go to meet the commissioner of the state, you meet the secretary of the state, and you say, okay, this is a product, I have got CDSA approval, you take it up. What are the policymakers' dilemma? And how do they make? Say, for example, every state has got a medical service corporation, which is essentially tasked with the task of procurement. So how do those medical service corporations, which are tasked with procurement, make the decision? They will formulate a group of experts. And experts will see, okay, yeah, this is CDSA approval, this is a cost. Let's decide to procure it. So what is the dilemma there? That how do I validate it? Is there any interest group in here? Because these are a group of clinicians who form experts. They may be super specialists in their field. They make a decision that okay, we should do that. But decisions are based on what? Decisions are based on the data that you are producing. And you will always produce the data. will say, okay, I have this product. Nobody will say, yeah, my product is not, it's not optimal. This is good. And so the decision maker's problem is that how do I decide? Do I need objective make? Because decision, as you can see here, are very subjective, based on wisdom of certain decision makers, a group of experts, quote unquote. So that is where the role of HTA comes in, to create an objective framework. Here, and I'm talking about HTA internally from, again, I said before, from a public procurement perspective. HTAs are also done outside public. Medical companies, the device companies will also do economic evaluation. That is a different thing I'm not talking about. I'm talking about from a public procurement perspective. So the decisions here are based on objective criteria. What are the objective criteria? Okay, show me your clinical evidence. Whom? Not to the group of experts, but to a specialized agency, which are like the INPH, IIT Kanpur, etc. Agencies, which will assess your evidence, the quality of evidence, which will also look into the cost part of it, because you will show, okay, this is the clinical effectiveness.
Dr. Somin, that is where my issue is that, you are again putting a lot of data that you need to have, right? And the innovator is really stretched to do their own things. Now, in that context, what I would like to have is, if there is an easy way to incorporate HTA matrices, right, for the research innovation startup pipeline, right? I mean, or if you can build a portal where the innovator can feed in some of the data, and the HTA matrices come out of it, that okay, you know what, whether this is good enough, not, etc., etc.
I got your question, sir. So this portal exists now, actually, as I was saying during the tea break, that this the portal exists. Medtech Mitra is the body where you should register. Medtech Mitra, if they find your topic, your concept of importance, they will do the validation. The question is that innovators are stretched of funds. How do I fund it? You don't need to fund it. You need to register your interest, your product, your details to Medtech Mitra portal. The patent will lie with you. The validation will be done by Medtech Mitra. Through whom? Through a third party agency. They will engage Medtech Mitra, ICMR. Medtech Mitra will engage agencies for doing it, not at your cost, but at ICMR's cost. Once they do the validations, they will, and this will help cut down the cost and time for innovators. This will be then, once it is validated, validation results are generated, it will be transferred to HTA to basically get an HTA done. You do not need to pay for it, because the government of India, DHR, is paying for it. We are not paid by innovators. We are paid by government of India. When I say we, I also means AIM Jodhpur HTA Center or INPH HTA. Each one of us are paid, our salaries and everything are paid from DHR's money. And our role is to basically, but we will ask you for data.
So in that breath, I would also suggest that maybe there should be an NDA signed between the agency and the innovator, so that they can freely, share their data without the fear that, all this data might be shared with some competitors, some it might leak, etc., etc.
Yeah. So some agencies do ask for NDAs, and we do occasionally sign NDAs. But whom are you sharing the data with? You are sharing your data with an agency which is affiliated with the Department of Health. You are not sharing your money. The money is paid for something by somebody else. So, NDA, so for the technologies that we have, I don't think we haven't shared any NDA with any other agency. None of the agencies ask for NDA.
So any innovator would have this concern. I was just wondering that, if you want to share, if you have to share the data with Medtech Mitra or HTA.
The biggest concern for innovator is not sharing the data. The biggest concern for innovator is the adoption of my technology. Because there you can make your money. Here is an agency which is telling you this is affiliated with Government of India. This is affiliated with Department of Health. They are not charging you.
Yeah. So they are just putting all the concerns out, so that
I can completely understand. You're playing in the devil's advocate.
Yeah.
That's important. So data, so far, as I just give to this, but so far only one agency has asked for an HTA. I know that that agency has not been prioritized.
Okay.
But we work with multiple agencies, not only us, there are also policies. I don't think you can see here a lot of these institutions and we have created and all. Each one has shared data, nobody has asked for it. Because they knew the value of it.
Okay.
So at some point you need to have a trust with the government.
Yeah.
You cannot work on this stuff.
I think like the idea is about NDA that can be done, but whatever what HTA was done not on that data. Actually, that data was they have already published.
Okay.
Or they have disclosed something.
Okay.
That only was used.
Sure.
Not the primary data that is used for the purpose. And they can like summarize the data. They can also do some samples or whatever.
Sure.
That the full data or the full data is not a full test.
Okay.
It's different.
Okay.
So we have to have some summary of the data.
Yeah.
So one more question I have is, while discussions, you said that HTA will give get the evaluation done by a third party, right? Or Medtech Mitra will do. So randomized control trial will be the best data. While it is true, randomized control trial will be the best data, but it is a very expensive data to procure. Very, very expensive data to procure. Now, as part of, for example, our PhD, innovators who are doing their PhD and creating a startup based on innovation, they would have collected enough data, more than enough data, which they will publish also as a scientific paper, right? Which will be filled with a lot of, data that assesses the technology, and these will be published in, Q1, Q2 journals, very respected journals, peer-reviewed journals, and the people who are reviewing is across the world, right? So I'm just trying to understand why this data will not be at par, why this should not be accepted, and why a randomized control trial, while it is maybe a gold standard, but do you think it will be really, it's a realistic data to be created by an innovator who is just out of,
So, Kuldeep sir, may I answer this question? Audible? Actually, there is RCT for other intervention for diagnostic accuracy study, the evaluation of any medtech technology. There is no need of randomized control trial. You could perform a good diagnostic accuracy study. What Dr. Shaha mentioned, yes, RCT is the gold standard for any interventions, other interventions, but for your device, your technology, your diagnostic kit, you need some good diagnostic accuracy test, and which may be completed within 3 months, 6 months period. And what Dr. Srivatov sir is emphasizing, if you want to do some third party evaluations, if you want to do, you don't have enough fund to do validate study, you can also share with the Medtech Mitra team. They will be they will be conduct the diagnostic validation study for you. So it is not the RCT is often needed things. Second things that regarding data sharing, data thing, HTA does not require any raw data. If you published your journal in a peer-reviewed journal, we trust and believe on the data. Many time what happened, the innovator for the new technology, when they send for HTA, they don't have any publications. So in that case, we consider the raw data, even not in the raw data format, even we want it in a draft manuscript format, or you submitted the manuscript some journal and you share that. We don't need any Excel sheet, raw data calculation, anything else, or there is no issue. So whatever it's available public domain, HTA trust more on that. Okay? Sir, it is clear?
We look into is risk of bias assessment. So is there any obvious bias in your validation form? For example, you are the innovator, you are producing the accuracy data. Is there any obvious risk of bias? If you can address that part of it, then data can be corrected.
So thank you so much, Dr. Soumil. And I'll very quickly run through. There are only 7 slides, so you don't have to wait too long. And the purpose of these slides is to make the HTA team aware of the program that we have, so that we can understand how HTA and our medtech program can align, so that we can take full advantage of the HTA concept and the services that the department can provide, right? So this is an AIMS and IIT joint program, one of the first in India, where a student can get their master's and PhD degree, but with a very strong component of not just doing research, but research, innovation, and startup pipeline. It's a very strong concept that we are running. And in the cohort, we accept students who are from the engineering background as well as from bio and medicine background. So it's a very diverse cohort, because we want the relevance of the problem to be integrated in the problem statement right from the very beginning, right? And each of the student has two advisors, one from AIMS and one from IIT. So there are lots of checks and balances which we do. This is our pipeline, and the reason of sharing this pipeline is because I think a lot of concepts, some of the concepts that you talked about in HTA, early HTA. So these we also incorporate, and we can probably see later, how where exactly we can map it. And I was not an expert in it. I was in the morning, I was trying to read up on HTA and try to see how our pipelines match. But this is identify, invent, implement pipeline, which was very famously started by Stanford Biodesign, and we have our own adoption to it. In the first two stages, need finding and need screening, you will be happy to know that our students actually spend their first semester in AIMS Jodhpur, where they go to various OPDs, IPDs, and OTs, and they talk to doctors, residents, patients, their relatives, to identify problem statements. So they do a very thorough job in need finding, like one of the HTA concept of population. So which population. So this is done very, very thoroughly in the first semester when the students are doing their master's or PhD. So they understand the unmet clinical needs very, very clearly. Then the second stage comes where concept generation and concept screening. So the teams actually, start doing research in IIT, and they're constantly in touch with the medical doctor in AIMS, where they build the prototypes, they validate, they test the prototype, the engineering of the prototype, and we also have an MOU between AIMS and IIT, where a small clinical trial can be undertaken as part of the study. So we do go through this controls, but these studies cannot be very big, right, as of now. And then in the implementation phase, they register their startup. They can probably choose our own incubator, or they can also choose an incubator outside our organizations, right? So this is our entire pipeline, and many of the HTA ideas might just figure out in this. Proof of the pudding is in the eating, right? So this is again to just prove you that we have more than 15 student faculty-led startups. About 4 of our startups have gone from they are already in the advanced stages. Got a lot of grants from government as well as investor money. We have 4 BIRAC big grant awardees. Each of the awardee gets 50 lakhs to build a working prototype. We had 7 MSME grant awardees. These are students, who got 15 lakh each per year duration. We have about 15 DVD biodesign fellows. They get 60,000 per month to work on their own startup ideas for a year. We have several publications, patents, and we also have 2 PMRF fellows. These are, some of our very, accomplished alumni and startup founders. And I'll just talk of, couple of them. Neha is right here in the room if people want to meet with her. So she just got the first Maha MedTech Mission grant which was the first edition which was rolled out in India. And that was a very, very big, I would like everybody to applause for her. We also have Dr. Kanika Singroha, who recently showed her innovation to Honorable Prime Minister Shri Narendra Modi, as well as the President of France, Emmanuel Macron. Then I cannot cover all the amazing startups, but another startup to talk about is Heliantra, done by three founders. One is a medical doctor, and the rest of the two, Divesh and Sayakar, from electronics and electrical engineering. So this is how our cohorts are generally formed. There is Servit Innovations, and Sambit is also here in the room. Likewise, there are a lot of innovators in the room, and if you get a chance, please talk to them. Rahul Parmar is also here with his Pro MedTech Innovations. And then I try to, sort of map, where exactly our pipeline and HTA goals might map. And then during the discussions, I felt that maybe our pipeline may map onto the early HTA, philosophies, or, for example, finding out which population you are catering to. So that is what we do in our need finding and need screening, duration. Then, what intervention? So that is what we work on when we talk about our, the technology we build, right? And during that time, we also understand our comparator very clearly as to whatever solution this innovator is trying to build, what is the existing technology, what is the existing solution that people are using, right? So we are actually, during the need finding and need screening, we are also, assessing and researching our comparator very, very clearly. For outcome, I could not really think of a very good map on our own in our own pipeline. But quite a bit of what HTA is promoting, that we have incorporated in our pipeline. Of course, there's a lot to be done, and that is where we seek your help. Maybe starting with an HTA clinic, where each of our innovators who are very accomplished could take your help. So in our bio design, this is what we really ask. Is this clinical need real or critical? When we are in the first stage, can we build it? Can we protect it? Can we fund our startups? These are the primary questions that our founders are asking, right? And will I be able to build my viable product? Can I fund my startup? These are the primary concerns. Whereas HTA is the clinical gain which is real versus the current standard, so comparator. Is it really worth adding that cost on the patient, right? So that is one area which I feel that we need to work a lot to get this thing also incorporated in our pipeline, that what is the current cost and what will be our cost will be, and how does it justifies, right? And then whether there is value for the health system's money, right? So these are the all up for discussions, because I definitely don't have a very clear answer for all those things. Thank you so much for your attention, and I just hope that after this workshop, MedTech program of AIIMS and IIT and HTA will work much more closely. Yeah, thank you so much.
So I will just quickly, sir, I think this is an excellent idea. The fact that Kuldeep sir is already here, so the idea of having an HTA clinic is absolutely vital. And I also discussing with some of participants during the break. So I think this half day, a few hours only, is enough to generate an interest probably about no way to copy HTA. Like the question you mentioned about outcome, there is no one answer to it. Outcome has to be very, very complex to it. Specific. Similarly, how do we develop it? How do we measure cost effectiveness? We were talking about how do you compare it, that what is the additional value, and when do you say it is cost effective? So I think a lot of those things would require more experience patients with you. So maybe Kuldeep sir will involve with HTA. And IPG will be more than happy to support, be working with your team as you think things will be done. Thank you.
Thank you, sir, for such a valuable presentation and interactive session. I would like to ask participants to ask any questions or doubts they have. Okay. Before we begin the next session, I request Dr. Kuldeep Singh sir to kindly felicitate our esteemed speaker as a token of gratitude and appreciation. Before we start our last session, I would like to request all the participants to kindly fill out the post workshop assessment from the same WhatsApp group we have shared the assessment form and kindly fill it positively.
Moving to our last session, but not the least, it's our last session is highlighting the innovative work and research contribution at IIM Jodhpur in the field of health technology assessment. It's my honor to invite former Dean Academics and Head of Medical Education Technology with key role in the Institutional Ethics Committee and Indian Sweden Innovation Council, Principal Investigator of several prestigious national and international research projects, including HTA, Genome India, and Nidhan Kendra. A accomplished researcher with over 250 scientific publications and over 40 reputed international journals. It's our honor to invite Dr. Kuldeep Singh sir to deliver the last session. Sir, we look forward to more insightful presentation. Over to you, sir.
Thank you. And it was a wonderful morning and afternoon for this half-day workshop on health technology assessment. And we are grateful to Dr. Somen Shah and Dhaval Parmar and Dr. Siddharth for giving the inputs. And I think he is a reflection of all the questions which are arising in our mind. And this is a beauty of this workshop, that is, it should be able to stimulate people to ask more questions, to think about. Maybe we cannot answer all the questions right now, but if you can share these questions in the chat, in the WhatsApp chat, that also we will try to answer those questions. So this place may not be sufficient to answer all the questions, but a lot of things are happening in the city of Jodhpur. And I think we are privileged, AIM Jodhpur is privileged to have the IT, and also we are privileged to have so many universities and so many academic institutions in the city. That is a rich culture. And the MedTech program is given a lot of impetus to the government agencies also to think about it. And as we have seen highlighted about the startups which are there, but now the time has come that we have to move at a higher standard. We have to increase our level of standards. That is, it is not only the ideas, now the program is born, we are doing the research also, we are doing innovations, but we have to think about how we can add the value to these, our startups. And here comes the role of the HTA. So as Dr. Siddharth was asking that HTA needs a data, it is not like this. We don't need a raw data, we need a data which has been published in some form. Unpublished also can be shared if there is no problem in the patent law. So you have to respect the patent of your innovation also. So we don't ask everything. Whatever study I'm sharing with you, which we have conducted as a part of the HTA at AIIMS Jodhpur, we never get the full data. And despite that, we are able to do the full analysis. Okay. So Now, this is an algorithm. So, although from the far it may not be apparent, but what we can say that in HTA we use certain models. And one of the very easiest model is the decision tree. That is, decision tree is that there are multiple outgoing of that decision, that it can end up with something which can be judged with the help of HTA. So this is an algorithm for choosing the HTA idea, whether this idea is relevant or not. Now, this from where we got these HTA studies. So the first and foremost is the state. We are located in the Rajasthan, so we are forced to get the ideas or some of the programs for policy for which HTA can be done from the state. So we have got few, but mostly we are getting from the ministry, from the DHR, and the other is National Health Authority. They are sharing some of the, they want to do the cost effectiveness. National Health Mission, MDMS program of ICMR, then ICMR itself, MedTech Mitra, and the innovators. So all these can provide the topic for HTA study. The completed studies which we have been able to do is, one is this, the first thing which we got was the study on the it was on the study of gentamicin for sepsis. So this was a program which was started by NHM in 2014. Pre-referral gentamicin injection, can it save the life of the babies? So that was the question. Now, at that time, this is another beauty of this HTA is that it was in 2014. This was a policy made by the government for the pre-referral gentamicin injection. But at time there was a lot of resistance because the people were not prepared. The manpower was not prepared. Nursing professional was not prepared. If anything goes wrong with the baby in between the transport, then who will be responsible? So it was not implemented at all. Now we did the study now in the current situation. Now we have a nursing and A&M nursing officers, and we have the doctors also at some of the PSCs, CSCs available, which can administer the intravascular injection, and they can also monitor whether the sickness level. So now we have more expertise. Now this will be very useful if a pre-referral for not only newborn, but even the infants, if they are given a gentamicin injection. So that will definitely going to have, and we have done the cost effective analysis of this study. So these are the scenarios which were there. And so ultimately the implication is that it is useful. Because the disease is a high burden, it is cost effective and life-saving. Timely treatment can be given to the baby. It also provides the equity of care to all the newborns and the infants. Second was the what we talk about, the Jan Aushadhi. Cost effectiveness of Pradhan Mantri Bharti Jan Aushadhi Pariyojana. So this study was also undergone with some of the inputs from some of the centers. We have collected the data, primary data, and based on that, it was found that this is very useful for reducing the out-of-pocket expenditure for the drugs which were procured from the branded medicine. This study was conducted in 9 centers, and we found that this is reduce the out-of-pocket expenditure. Dr. Beva Joshi, who is here, she was a part of this study. Then drug-resistant epilepsy. Now, epilepsy is very common, and commonly clinicians sees this epilepsy disorder in a community setting. And sometimes the drugs are used. One drug is used to the maximal amount, then the second drug is added, then the third drug is added, and the drugs started having side effects. So here, we can have the for the study for the patients who are going to undergo some phase 2 studies which are invasive for finding out the cause of epilepsy, whether it is effective or not. Now, the time at which this study was conducted, we have only few centers in the country. AIIMS Jodhpur was one, and there was one center in Mumbai and some private. So we thought that it is not possible to collect the data from the limited center, but we are continuing with this study. And this culminated in another study, that is if we can have the effective national health program for epilepsy control. So this has generated a lot of interest among all the stakeholders. Another device which won the prize also in the ICMR national activity was the portable intracranial bleed detector. Now this is a near infrared based device which can detect the bleedings when the patient is having traumatic brain injury, because a lot of time is wasted in shifting the patient from one place to another place. So if we can find that there is a intracranial bleed, they can be referred directly to the neurosurgical center or where the facilities are available. So we can bypass the time, we can increase the utilization of the golden hour to provide the care to these patients. And we found that this is very useful if it is budget impact analysis was done, and it was found if it is procured, manpower is trained, and all the ambulance are provided with this. This is very useful. Rather than having in a tertiary care center, ambulance and the CSCs will be the most useful place to keep this device. This is all about this technology. Now we have that NHM has another program that is reproductive, maternal, neonatal, child, adolescent health plus nutrition. Now this program is conducted at all the places, especially the Anganwadi centers. The CSCs have been they have been converted to the Anganwadi or not Anganwadi, but this Ayushman Mandir centers. And this Ayushman Mandirs, they provide the basic care to the preventive promotive health. And if this, how the utilization of the service occur in this place, whether it is a cost effective or not, this was assessed during this study. And we found that the proper utilization of this can be done, then the A&M, the nursing staff, as well as the medical officers and the utilization of the time, they can be used for preventive care for the reduction of the mortality among the mother and the children, especially nutrition related. This was another device which was prepared by IIT Kharagpur. It was actually nurtured as a part of the MDMS program from IIT Kharagpur. IIT Kharagpur is venturing on many of these devices, and they are being subjected through the MedTech Mitra to the HTA. And we tested these devices from the lab to market translation. So this is just a simple blood plasma hemoglobin estimation, whether it is cost effective or it is useful as compared to the other devices. And what we found that the implication is that it can be used in a high burden area in the rural areas where the anemia is very common. And it can be very useful for PSCs, but the further long-term research is required in this to collect the data for the budget impact. Another device is the vein finder. When a baby comes with a serious condition, they are in shock, and we are not able to localize the veins. So whether this vein finding device can be useful. Now, what we find that we studied all the devices which are available in the market, from the simple device which cost around 9,000 to the laser-based device which cost around 6 lakhs to 7 lakhs. And we found that this is a very useful device when patient is requiring IV cannulation. But it only the preclusion is that if there is a budget is available, then you can use it. So that was a budget impact analysis of this device. So it is a useful device provided you can have the money to procure it. So may not be required in a centers which are like tertiary care center where the expertise are available, but may be very useful for a primary health center or CSC where the nursing officers are available. And also there are other venous access devices they can be compared to, like intraosseous infusion, which is very easy, can be done by simple, any person, even a community health worker can do it. So again, the comparing of all these devices will give a lot of insight into which device can be used at what place, what is the cost, and whether the economic evaluation permit the limited resources which our country has. So that's why these studies are very important in assessing the value of HTA. Again, there are many studies which we carried out as a part of the Rare Disease Center at our institute. We also studied the telemedicine in the tribal outreach area. We estimated a device which is known as DDPCR for spinal muscular atrophy. which costs around 10,000 for diagnosis, but we are able to do in 500 rupees screening for this condition. We also conducted a PhD study on epilepsy. That is, sometimes the epilepsy patients are misdiagnosed, and misdiagnosis lead to a lot of referral, lot of use of the manpower, and also mistreatment also. So that's why correct diagnosis of the epilepsy is very important. So national health program on epilepsy will be helpful. Also, we analyze the screening program, whether it is a newborn screening is more effective or a pregnant woman screening is more effective. So we found that if the pregnant woman is subjected to antenatal diagnosis, before that screening can be provided, it is more cost effective than the newborn screening. If you do the newborn screening, a lot of human resources are involved in collecting the samples, transporting the sample, and doing the analysis. But in the pregnant women, they are most suitable because they are most receptive at that time. So pregnant women, whenever they are pregnant, they first consult the doctor. So if the gynecologist thinks that she may be having some hemoglobinopathy, so they do the screening. If the screening comes positive, then the husband is also asked to come for the screening. If the husband is also positive, then only we go for the antenatal diagnosis. So in this way, we can minimize the cost, cascade screening cost of the treating these patients. We also conducted one other study about the risdiplam, which is a drug of choice for managing the patient with a spinal muscular atrophy. Now, this study was given to us by Tamil Nadu government, whether this risdiplam will be more effective than the nutrition or supportive care to the patients. So we found that both have the advantage, and nutrition support should be given, but along with the risdiplam, it will increase the patient care and their side effects. We also have conducted some studies which are based on the AI. So one is that in the cancer planning, when we are planning the brachytherapy or the cancer, so some software is required, which is very costly and which takes a lot of charges. There is an inbuilt charge because of the patent. So if the mVision AI contour software can be useful in defining the need for a radiotherapy or brachytherapy in the cancer. So this is also, we found that this can be useful, but the innovator which is doing this has again the patent issue. So the charge will be more. We also are continuously doing the study, which is the costing of the health services in India. Now, this is very important. As you know, the Ayushman Bharat program is there. In the Ayushman Bharat program, there are two or three components. One component is the insurance scheme, and second is the Ayushman Mandir. So in the insurance scheme, government is providing 5 lakhs to the patient. Now, these packages are prepared based on the CHSI-1 study, which was conducted in 2017, when the national health policy was just out. So in that, we had the facility for package preparation for basic things, like basic broad specialties, but we missed those specialties which require like diagnostics, emergencies, and the non-communicable disease or super specialty services. So the package is still not there. So in order to find out whether they are going to be effective or not if they are introduced in the NHA. So this study is being undergoing. This ongoing study will complete by December. So we'll get to know what are the costing of these endocrine, neonatal, pulmonary medicine, or emergency services, or cardiac centers, cardiac surgery, and other things. So this data will be collated, and then this will guide the ministry to take action for preparing the package program for inclusion in the Ayushman Bharat. So again, these are the things which helpful. So this type of studies can also be done. Then another program which is going to be launched is the antimicrobial stewardship. That is, there is an indiscriminate use of antibiotics. It causes a lot of antimicrobial resistance. So whether this stewardship program, which is already there, if it is introduced gradually, that it will reduce the cost of the use of the utilization of the antimicrobial or not. So this is also one of the study which is going to give a lot of informations for the policymakers that how we can make it more robust. Antimicrobial use can be optimized. Again, there are many other studies which we are doing as a part of our center. And another thing is IVIG is heavily used in also condition. There are 5 conditions which have a definite role, but the other condition they don't have the definite role. But still they are able to reduce the mortality and morbidity. So if the IVIG is introduced in other conditions, whether it is going to be effective versus the cost we spend on the procurement of these medicine. So this is again an ongoing study. We have publications from the HTA, and you can come to our HTA center, and we can have discussions. Lot of things can be done. There's a lot of scope, and now like we are moving toward AI. So AI is also like AI and genomic studies. There are two things which are like which can be like they're doing the automation of the things. That is genomic studies. You just ask NGS and gives a report, but the cost is very high. So if we can inbuilt a system where the clinician is also there in between, then it can reduce the cost. So just simple changes will reduce the cost of the testing. Similarly, AI, if the AI is not guided by the like human resource, it will not be useful. For example, chatbot, if it is totally AI based, it may give a wrong information to the patient. But if there is a human in the loop, then it will be more useful. That is, at a one point, the complex questions which are asked through the AI by the patient can be answered by the clinician. This will be very useful. So these type of innovations are more important. Point of care device, AI use in the automation as well as in the care of the patients, and how we can like improve the health services which our tertiary care is providing. For example, at AIIMS Jodhpur, we have only 960 bed, but the patient's footfall is around 9,000 per day. Out of this, at least 100 patients requires admission. And the thing is that we cannot cater to everything. And there are things which the patients can be managed in the outside center also, in a sub-center, PSC, but they are not utilizing. The trust of the patient is so much that they come to the AIIMS directly. And that's why we are overburdened. And we have to recognize which patients needs a more care. So triage, forward triaging, if somebody can develop this type of technology, a forward triaging where the patient can be held at some other hospital for some time before the patient is referred to AIIMS Jodhpur, it will markedly reduce the cost. Neha is doing the research on the transport of the newborn. That is very important because we are able to reduce the infant mortality from 30 to now less than 10. Even the best center of the Kerala, it is still 8 or 9. It is not reducing beyond that. And the reason of this is that there is a need of a highly specialized care for the newborn, which cannot be provided. That so much technology enabled centers are not there in the country. So we have to find out through AI which needs say transport, which can be managed there only. And what are the common problems with the newborn? That is hypothermia, hypoglycemia, acid-base correction. That can be done at the peripheral center also. So again, a reverse triaging is also very important. Once the patient comes, he gets improved, he should be referred back. So the bed is available for another patient which is sick. So I think a lot of innovative ideas are there, and together with the medtech students, we can do a lot. And I think that there may be a lot of questions in your mind. You can ask these questions right now, or you can ask in the WhatsApp chat also. So I think this is all about. We conducted a lot of workshops. We have a team, Dr. Mamta, Dr. Amit, and Manmohan. And we have a team from the, like Anjali is there. She's as the CHSI. And Sanju is CHSI. And also we have other faculty members at AIIMS Jodhpur, which are interested in the HTA, Dr. Varna. And we have faculty backup also. And the most important thing is that we have a pool of experts. That is for the neurosurgery, we contacted Mohit Agrawal. For emergency care, we contacted Dr. Bharat Chaudhary. So we know that who are able to do put the inputs in that. We have a cardiology, ophthalmics, microbiology, diagnostics, radiology, everything is there. Only thing is that we have to assess based on this early HTA, what is required, and we have to do more research. We have to find out in a depth of this study, what is the impact of this technology. whether we are just devising for the purpose of patent or really we are going to help the patients. So patent and patients both are important, but for doctors it is more important is patient. So you will see that less of the patent among the doctors, more of the patient among the engineers. But that is also required because patent also gives you importance, and also you can get an opportunity to commercialize and have more profit, and at the same time you have a liberty to make the patent open to the public. That is, you don't charge for the patent. If you are patented technology, you open it. That is another step which a medical technology students can take. Don't be like endowed with the patent. Make it open. Make it relax that, okay, you can use it freely. I think this is all about. Any question or any comment or? Okay, thank you.
Thank you so much, sir, for such an informative, insightful presentation. I now request Dr. Varna Vyas ma'am to kindly felicitate eminent speaker with a memento. Round of applause, guys. I know you are draining out, but please bear with me a few more minutes. Then we head for the lunch. Delicious lunch for you. So please. Invite, please, Kuldeep sir. I request Dr. Kuldeep sir to kindly felicitate our guest of honor, Dr. Ankur Sharma sir and Dr. Varuna Vyas ma'am with a memento. I guess you the participants are filled. The participants are filled with all the pre and post questionnaire, I guess. Okay, thank you so much for responses.
Every successful event is the result of collective efforts, guidance, and many individuals. It is now time to acknowledge and appreciate those invaluable contributions. I have the honor of inviting Dr. Kuldeep sir, Principal Investigator, RCHTA AIIMS Jodhpur, to deliver the vote of thanks. Thank you.
First of all, I am thankful to all the participants because you are the stakeholder and you are the crux of this workshop. Because without you, this workshop would not have been possible. And secondly, I am grateful to all the speakers, Dr. Krishna Sahu from HTA in Delhi, Dr. Siddharth, Dr. Somen Shah, and Dr. Dhaval, and all the faculty members of our institute, as well as all the research staff and the HTA staff at AIIMS Jodhpur. And we are open to any suggestions or comments in any form by email or WhatsApp or by personal talk. And we are thankful to all this audio, visual, and other arrangements which have been done by this portal. Thank you very much.
As we concluded today's workshop, we reflect upon a truly enriching journey from understanding the foundation of HTA and its role in evidence-based policymaking to designing need-driven health technology, formulating research questions using the Peacock framework, which is well taken by the Sahu sir, undertaking evidence requirement for public health programs, appreciating economic evaluation methodology, and the learning about the remarkable work undertaken by AIIMS Jodhpur. Although this workshop comes to an end today, we hope it's marked the beginning of lasting professional relationship. We are now a part of one professional family. All the members have been added to our WhatsApp group, which is HTA Innovation Workshop. And we look forward to staying connected for future collaboration, strengthening knowledge, and address any queries you may have. On the behalf of Resource Center Health Technology Assessment M. Jodhpur, we sincerely thank all the eminent speakers, honored guests, participants, and the organizing team for making the workshop a great success. And as I, Dr. Anjali, with my co-anchor Sanju, yes, we are wishing you best of hard work for your studies, for your innovations, for your research. May these all sessions are useful for your studies, for your research and innovations. And with that, we now invite everyone to join us for the lunch. Have a wonderful day ahead. From our side, signing off. Thank you all, and we are delighted to hosting you.
One more request, please all the participants fill the feedback form, feedback there on the left side standing, and take a moment to share your experience or valuable feedback. Thank you.
बंद कर दूं ना इसको भी बंद कर दूं तो
मेमोरी कार्ड